All right, thank you all very much for staying for the afternoon session. This is going to be a little bit intimidating, sitting up here looking at the number of people that we've got involved at this point with a subject that Dr. Register and I feel very strongly about, and that's dealing with rural trauma and ultimately allowing us to start this committee some 2 years ago, just a little over 2 years ago, and what we've been able to accomplish at this point. So it's allowed us to get a seat at the table, and I do appreciate the GTC for allowing us to do that. So one of the things that we were able to do was to get the first ACS rural consultative state system visit that happened in early February, I think it was. Correct? January, sorry. Time just eludes me at this point in my life. But they came back with a lot of different recommendations, but specifically there were 20, how many, 26, 27?
You're asking me for advanced math.
Advanced math, sorry. 25 different specific rural recommendations to us that are divided into 4 categories. And that's what we came to talk about today, was to try to put together some action plans and some details for this. There are 4 different major categories: that of trauma system infrastructure and how it relates to the rural trauma system in Georgia. Of that, there's also a major category of the trauma system components and their integration together, and how we deal with the larger trauma centers, but also the state. And then data performance and improvement, specifically in relationship to the level 3 and level 4s, and then disaster preparedness and military integration with the rural setting in Georgia. So those are 4 major topics that they have. We've handed out those recommendations to you. Now, in the bold face on this sheet are the kind of urgent things that need to be addressed quicker than the other components. And so there's a lot of things that we're doing as far as the rural committee at this point. And we have 4 meetings scheduled for next year, which you can find on the website. They do correspond typically a little bit before each one of the GTC meetings, so you're more than welcome to get on there. And my usual people that are here, I expect you on those calls and to help out, is because you're the backbone of this committee. I expect y'all to speak up today the most. Uh-oh, I'm getting sidebarred.
I love it.
Okay. All right, so we're going to go ahead, and this is an open meeting. I really hope that you will please talk. We do have people online, of course, but and we need to pass around my. We're going to have a microphone assistant.
We'll do that.
Okay, all right. So we're going to divide these categories up. Dr. Register and I have talked about this, and I'm going to take the first major and the third major topics, and she's going to take the second and fourth. And we're going to each talk and try to facilitate some discussion and what we need to do and how we need to do it, hopefully going forward in the next year, 3 and 5 years, hopefully to come up with a plan for the level 3 and level 4 programs. All right, so the trauma system infrastructure, probably one of the broadest categories. The first things that they subdivided into 3 parts. And that was perform a comprehensive resource and needs assessment addressing the following. And the 3 things that they touched on were funding for the rural trauma system, emphasizing the rural aspect of both EMS and trauma hospitals. Evaluation of rural trauma capacity to identify gaps, including EMS, trauma hospitals, and transfer capabilities, which you pretty much have heard a good bit about so far today. And the recruitment and retention, and primarily focusing on rural providers, nursing, and EMS. So to start off the discussion with this at this point, we wanted to already tell you some of the things that we're doing. Of course, we're looking with funding with GTC and with Liz and Dr. Ashley's assistance, trying to improve funding. We know at least we now have a benchmark of where we have been. It's probably not where we are right now because of inflation and other issues. And now with the Gray Book statistics or the demands coming out, things have changed and they're probably more expensive. And also realizing that through our analysis of the data from the level 3s and level 4s, especially the level 4 centers, they really don't know how much it costs to do a lot of things, and it's hard for us to figure that out. So we're working on that, and with the plan of trying to redo this based on Gray Book recommendations, and within the next probably 2 years. And so what I planned on and talked with them about originally was probably trying to redo this in the year 2025, and redoing the evaluation of the level 3s and level 4 centers. We've also talked about geopolitical mapping and geomapping of the system in Georgia, and trying to look for gaps, both the so-called ambulance deserts, which I heard that phrase come out this morning, I think is an interesting process. Looking at EMS, trauma hospitals, and transfer capabilities. I'll tell you my experience with that is when I was going through a level 2 consultative visit several years ago and dealing with, being a little rural guy and trying to just help out in the system. Mike Chang was there, who was at the time the chairman of the COT, and he was one of my reviewers. And he asked me a question, and I saw the opportunity to get my digs in just a little bit. He asked me where the nearest level 1 trauma center was to me. And I told him it was University of Florida in Shands, 134 miles away from me. He said, no, where is the nearest level 1 trauma center to you? Still didn't ask the question correctly. I said, technically you are at Mobile, Alabama, at University of South Alabama, at 135 miles away. No, where's the nearest one in Georgia? You finally asked the question correctly. It's in Macon, 136 miles away. So I'm in the middle of nowhere. Okay, so that's where a lot of us are. And so that's one of the things I want to look at is how we can start to piece all this together. And then, of course, now with the state legislature is working on a piece through, I think it's University of Georgia, and looking at recruitment and retention, primarily focused on rural providers, nursing, and EMS. And so I'll kick it off and let other people start to talk here. Don't be shy.
Everybody speak at once.
We're all friends, and if it gets heated, it gets heated. We need to have this discussion, and we need some open and honest dialogue. Wow, I didn't realize we were doing everything correct so far.
The recruitment and retention that's done by the legislature, do we know, is that gonna be reported out in the January session, like January, February? Does anybody know the answer to
I
that?
assume, are you referring to the study committee?
Yes.
That was looking at workforce, so that came up this morning, and I think, when they did the conclusion, when the conclusion of all of the hearings and things takes place, and they write up their recommendations, that's when we'll hear about it. It may not be as early as the kickoff. I don't know.
All right, so I'll tell you a little bit about what we're doing, where I'm at, and see if this will dovetail anybody else. So we had started a relationship with FSU College of Medicine when it started years ago. We're the only site outside of the state of Florida that accepts their students. We have 5 full-time embedded students that do their junior rotations with us. And from that program that we've dealt with them for about the last 14 years since they started, we've recruited back 3 physicians that are attending physicians at our institution now that were FSU students. And only one of those, though, actively rotated with us at Archibald in Thomasville, Georgia. The other 2 had heard about it. And we actually, I think, have, I'll take that back. 2 students have rotated with us. They're actually back. We have actually 4 now attendings. We have a new anesthesiologist that's there that actually did a senior rotation with us as an anesthesiologist. So we're trying to build those people homegrown. We now have relationships with PCOM, Philadelphia College of Osteopathic Medicine in Moultrie. We also have a core site. We're becoming a core site for Alabama College of Osteopathic Medicine from Dothan, Alabama. And we're trying to actually open up the other half of the Southwest Georgia campus between Albany and us for MCD. Albany has a well-established Southwest Georgia campus. So those are things we're trying to do to grow physicians. Nursing wise, we have a nursing school there with South Georgia or Wiregrass Technical College. We take students from FSU and all the other Darton, from Albany, multiple other students. Anybody else has ideas, we're willing to listen to those. The biggest thing I see a problem is being on the faculty. I'm actually the surgical advisor for the faculty for the internal medicine residency program at Archbald. Being the one weird person there on faculty as being the surgical representative. They wanted surgery input to their training. And the biggest problem we have with students is housing. We can't house people, and we have very little apartment complexes in Thomasville. They're just starting to build apartments like you see in bigger areas. Most people have to rent houses. MCG is looking at renting a house for their students full-time. We'll take any other suggestions that anybody else has, that we're trying to grow people on our own. It'd be nice to have maybe a state office that facilitates medical education and nursing education to allow for some experiences. I don't know what else to do. Please.
So I'm in Albany.
Albany,
Phoebe,
yep.
and so I appreciated the comment that was made this morning about having to grow our own, because not everybody's beating on the door to come to Southwest Georgia. So we have a partnership with Albany Technical College and Albany State University, and we're in the process of building a nursing school across the street from the hospital that will have housing. And then probably about I don't know if it was 5 or 8 years ago, everything kind of runs together. We built housing for our medical students also, which is right there in close proximity. That was the only option we had because it was difficult to recruit.
Know that AHEC, if you've ever heard of AHEC, the Allied Health Education Consortium or Council, I think it is, also does a lot of housing. My son participated in that when he was at MCG. They don't have a whole lot for nursing, which is interesting. It's unfortunate. Albany, I know y'all had done that, which was unique. We are landlocked. We have no land available to do anything around us, except we take up a parking lot. So that's our problem, is where we can do other things internally in town, apartments. The problem is we're competing right now with our small local university, Thomas University, who's now started a NAIA football team and a basketball team. So now they're taking athletes in that are competing against us trying to get housing. So a lot of the local apartments that are available now are no longer available because of that.
What options do the smaller hospitals have for tying into the program for medical students where communities would pay for their medical education and in agreement for them to practice in their small town for 3 or 4 years?
Right.
Is that a national program? Is that a community-based program? Is it a state-based program or what?
There's a couple of state-based programs at this point. There are rural health scholarships in Georgia. There's also, I know that MCG has done what they call their 3+3=4 program. I think is what they call it. So they've accelerated their medical school process to 3 years, so they can finish up in 3 years. It's called the Peach State Scholar Program through MCG, where they graduated their first class of those individuals last year in May. There were 6 of them that participated. They're guaranteed a residency program in Georgia. They don't have to go through the match. And then they have to work in Georgia for at least a year. I think it's 4 years minimum and they'll pay for their entire education. So there are options out there. They have to go to a rural underserved community. There's a lot of different options out there they can do. Of those 6, I know one did pediatrics, one did OB, one did psych, one did surgery, and one did medicine and one did ER. So those are all considered the primary specialties in that group. So I think there's actually a program being developed at Emory that's similar to that. I'm just not sure what the name of it.
Yeah, is it worth investigating from the community or the town level and say, hey, listen, are you willing to put money in to do this, to draw those people here? Like maybe even hospitals,
Right.
they may not have the money, but somebody in those local municipalities that would fork over that money to draw those people in.
You make a great point. So with the AU
Mhm.
MCG 3+
Sorry.
program, so something kind of the disconnect is, where are they gonna work?
Right.
They don't have that figured out. And, because we take AU or MCG residents, surgery residents, and that's something that Dr. Holston and Dr. Hess, Dr. Patton, kind of all the major players in that 3+ program we've kind of talked about, because, I mean, for y'all that don't know me, I'm Alicia Register. I'm one of the general surgeons here, 2 blocks down at Crisp Regional. And we looked at, do we have the volume and the finances to support a 3rd surgeon? And the answer was no. So on one hand, we're being told we need more rural providers. We need more rural surgeons. And yes, that may be true, but who's going to pay for it? Where are they going to work? So if we're cranking out more surgeons or more, all I can speak for is surgery, but then there's not hospitals that are raising their hands saying like, hey, we're committed to then offering them jobs, then you're gonna graduate people that then there's not a place to work. And so to my knowledge, that last step in where you're gonna work has not been ironed out yet. And so I think it's a great effort, but unfortunately 5 years from now, when that surgery resident is now looking for a job and their tuition, I mean, everything's been paid for, but then there's not a hospital saying we're gonna employ you.
So what I'm hearing for you is that's not a need then in these rural hospitals, is to have providers. Is that not true or?
Well, I
No,
think,
it is.
yeah, I
It is,
I
but-
think it's who you ask. Are you asking the people that are writing the check? Or are you asking? No, really, I mean, and that's where I would love, I mean, a big part of the solution has to be having the GHA. And like and that's what this is for. That's why we have the administrators group of the, the GTC, which is a wonderful, much needed addition. But it's more than trauma care, I mean, this is part of trauma care, but it's a bigger problem. And we really have to have all stakeholders aligned with the common goal, because if you have this section working on this, but then you don't have somewhere willing to hire them, then now you're left with a surgeon with no medical debt without a job,
Sure.
It's interesting because if you go back and look at kind of the timeline, I think it was 2006 when we had, from a medical education standpoint, when we finally had for the first time, enough U.S. graduates of medical schools to fill U.S. residency programs. And so, one of the things that the previous governor of Georgia did was increase the number of slots in medical school.
Yeah.
Okay, so we've increased AU. I think Emory ultimately increased their size. School started in Savannah now with a campus of AU there. PCOM came in and started the Duluth campus in Atlanta. They started the Southeast campus in Moultrie. So in the thought process was at that point, well, we're going to build more medical schools. They didn't think about residency programs. So we started thinking about residency programs some 8 to 10 years ago, and those started, well, we're not thinking about where jobs are either now. So we're taking it one step at a time, because it takes, to build a surgery resident, build a surgeon is going to be minimum 9 years after college. So you got some time to wait. Well, the problem is we didn't think about this some 5 years ago. So we need some idea of where those jobs are available. But the problem is things may change. I may get another surgeon who's for some strange reason, wants to come to Thomaston, or somebody that Alicia, she married a guy
You're
from
right,
Cordele, and she comes to Cordele, and so there are those things that can change, and all of a sudden that job's not available anymore. And so what do? We have to have kind of a clearinghouse of where the rural needs are, and that's where I think the geo mapping comes into play, and what needs are, and ultimately I think possibly the state kind of helping with that possibility. If instead of paying them technically, the hospital may be responsible for their salary as an employed physician, but maybe the state guarantees that they'll pay off that person's loans when they come there and take that burden off the hospital itself too. I don't know.
And it's also probably ER docs too, right?
I'm just using surgery resident because, I mean, we're just thinking about home at this point, but it's ER physicians, it's medicine doctors, it's everything. And it's a global, I mean, it goes even into just rural health, and ultimately what this office here in Cordele is for is the State Office of Rural Health. Those all specialties at this point.
Well, and I was gonna say, I think a component of that we don't consider sometimes is our physicians are aging out, and it never really occurred to me until I started looking around the table, and I was like, oh. And I mean, and I'm putting myself in that, because I'm over 50, so I'm putting myself in that same bucket, and I'm thinking to myself, in 10 years from now, not even 10 years, half of our people will be out. So what are we doing in preparation for that? So I think understanding the age and where they are in their career, it needs to be a factor in, setting up this, infrastructure.
So I don't have much to add as far as physician recruitment and sustainability, but, from a nursing standpoint, I hear you, presenting these ideas of like, if there was a nursing school the problem isn't that there's not enough schools. The problem isn't that there's not enough nurses. It's that there's not enough nurses willing to stay in the hospital. And that is because of a culture that administration, these bigger facilities, have created. And I think in a rural center, you can't afford to just pop up a nursing school and new housing. See if you can put that money towards helping keep the nurses that you have. Have a staffing ratio that's set that nobody else has. Like some of these hospitals right now, nurses are taking 7 and 8 patients a night. If you can go in and advertise that your patient ratio is gonna be 4 to 1, you could pay them less money and they're gonna come work for you. The money isn't everything. I know personally speaking, I would rather go into a smaller facility making less, having a safer and more realistic working environment than I would in a larger facility where I'm gonna make more. And then if your facility can afford to invest that money that you're talking about for growing, because there's enough of them, they're just not working at the bedside anymore. Retention is gonna be the biggest key, and the way to keep nurses is there's no pension plans anymore. If your hospital can invest or your community can invest to nursing or helping your hospital sustain its resources, give them back a pension plan. There is no future for the younger generation as far as retirement and money. And I don't know what that looks like financially. But if your community and your hospital is willing to spend the money, spend it to keep the nurses that are already in the system, because they're there.
One comment directed to yours about, so it sounds like there's not really a physician shortage. I half agree with you. I think we need to look at the data differently. And that's where I think this geo mapping is gonna come into play, whether it's talking about EMS resources, where are ambulance deserts, where are physician deserts? So I always hear this statistic, and y'all probably can correct me if I'm wrong, but everybody always says there's 79 out of the 151 counties in Georgia that don't have a surgeon. Well, it's because there's not a hospital to operate in that county, and not every rural county needs a surgeon, because like for me, I think we serve probably about an 8 or 9 county radius. Dooley County, where I actually live, doesn't have a hospital anymore, but they don't need one because of the population. So instead of, kind of throwing out these statistics of, oh, there's 170 something counties without a surgeon, why don't we look at it as like a per capita ratio? So kind of like nursing ratios, like what's a safe patient to nurse ratio in an inpatient, like on the floor, on a med surg floor? What's a safe patient to surgeon ratio? And then let's map out those areas in Georgia where we do need, whatever kind of physician you're looking at. We're surgeons up here, so that's what we think about. But I know pediatricians, we really don't have enough pediatricians in rural Georgia. We really don't have enough GI doctors. We really don't have, there's some ER is a huge thing, and, so I think it's how we are looking at the data and the map of Georgia to determine where do we need more of what kind of resource, whether that's EMS, whether that's nursing, whether it's what kind of physician you want to talk about, rather than like a county to county. And it may also be like how the funds are distributed, especially like EMS, it's like county based. So You know, that's like a whole nother conversation that hopefully we will have today is, you know, I mean, do we need to rethink how we distribute, you know, how we organize it? You know, does it need to be more of a regional based rather than a county by county? It's like, I don't know, that y'all are the experts in that. That's why I'm kind of staring at y'all during this in court, you know? But anyway, but then also, so totally separate on your comment, April. So, I think actually, wasn't it at the last T-Quip, the keynote speaker was about compassionism, that if you feel valued at your workplace, you're more likely to stay. Not necessarily how much money do you make, but do you feel valued? Do you feel heard? Do you feel like you're making a difference? And that's what's gonna more likely keep you at a job. And so again, I can't stress enough how important I think it is that we've added the administrators committee, because they're the ones that really need to hear this too, because they're the ones that ultimately make the decisions to run the hospitals. So anyways, I think I got us off topic. Will you bring us back on
Well,
topic?
I was about to say, we got about 20 more minutes to talk
So-
about number one, so, and you've only done.
No, I know, I'm big shot. So that's not something we're gonna solve right now.
Conclusion,
But
I
just-
guess, though, we need to come up with, I don't think we're supposed to be the answers here, Liz, but are there resources that we can, I know that EMS has the ability to look at all the medics, like where they live. Do we have that for nurses? Do we have that for physicians? That we could at least, I heard yes.
Yeah, there's a whole GDAC site that dedicated to looking at healthcare providers, and I think Dr. Medeiros already said this. I think we should wait till that Senate study comes out with a lot of this was discussed at major, they had 3 all day long hearings about this, so there will be some meaty recommendations that come out of it. One of the things that in my notes, I think the idea of like a clearinghouse and like some sort of geo mapping and a per capita, like those are data points we probably can work with partners to get some of those things. So I think that will,
Okay.
but we can probably like work on some of those things and revisit this part. That's a much bigger, it's a much broad, we don't have as much
Right.
control over
Right.
this one. We have control over some of the other.
This may be just shuffling the chairs on the Titanic, but what some local ERs are doing are getting rid of their physician component in their emergency room and populating with mid-level providers.
Right.
I don't know if that's a good idea or a bad idea, but it's the reality of the economic situation with these small rural hospitals. But the issue still is, how are we going to recruit those types of individuals to stay there? And maybe it's a grow your own type of a situation where the hospital pays for your nurse practitioner advancement or something.
And I know several do that. There's also increasing programs related to advanced practitioners in the state of Georgia,
Right.
and around surrounding communities. So, all right, we'll continue to work on that topic, but I think what Liz had said, mapping and some of the, waiting for the, final report from the, Georgia Legislative, Focus Group. All right, ensure involvement and participation of the rural trauma hospitals and EMS in an inclusive Georgia statewide trauma system plan. Now, I think, this is a little bit dovetailing on one of the things that Dr. Dunn said in a previous meeting, was that he had been, he was the vice chairman of the GTC, and he didn't know we had a rural state, or we had a Georgia state plan at one point.
Right.
And I think now we know that there's a plan, but how are we not revamping that plan? With that plan being revamped right now currently, is there any representatives from the rural community on that planning committee?
We're not really working on the plan
Oh,
just
okay,
yet.
okay.
We're still working at the leadership level to do the 30,000-foot view thing. That was the high priority on the full system console,
Okay, right.
was to do the crosswalk of how we want to take this, what they hated, which was our dyad leadership of the 2 agencies, and turn it into like a strength and make it. So we have to figure out our crosswalk. And then I think once we get the advisory group together, we can have the right people in the room to start doing a plan that has all levels of stakeholders.
So with that said, is there anybody involved? I'll be the devil's advocate here. Is there anybody involved in that 30,000-foot view that has a rural focus?
For the crosswalk,
Yes.
well, that's really just how the leadership of the state is,
Right.
who has
That's before the plan is even done.
Okay,
Yes.
yeah, I'm just saying, you know, we all have different priorities, you know, where we live and what we do. You know, my priority is probably a little bit different than yours, you know, where I'm at. So that's why I was just saying, you know,
The Systems of Care Advisory Council that we're trying to build will have all levels as stakeholders, designated hospitals, non-designated hospitals, each levels, rural health. And then I think we just expand from there. And my intent is to fully have not just that council, but the subcommittees as well. Not that I want to create extra committees, and I mean, we could tack on to one that is already built or, but the initial planning stages of what the leadership structure and is, I think that's more what we've been trying to.
sure. Any other comments based on that?
You know, I would say you can tap into the RTAC network,
Right.
throughout the state to pick representatives from all aspects of the state to participate in that plan development. Maybe we revise that plan every 3 years.
Right.
You know, and I think that would.
I think it's a very important thing, you know, to mention that is kind of the revamping and redevelopment and re-inspiration of our RTAC system across the state needs to be a major focus, I think, of what we have to pull everything together from the rural and, you know, I mean, I know we always look at it versus urban versus rural. In all honesty, a lot of the RTACs have a rural focus and an urban focus at the same time. So putting that together allows us to kind of stitch it all together. You know, it's like a quilt, you got all these different patterns, but stitching it together, I think is where the RTACs come in.
We have the new position that will be coming in shortly to kind of be the gel that keeps
Right.
all the parts together.
Sorry, Dr.
And
Madera.
our office is committed to bringing that rural emphasis on the trauma system.
And just on a personal side note, when it comes to building the systems and working to ensure, because looking at the actual statement, it says ensure involvement, participation of the rural trauma hospitals and EMS in an inclusive Georgia statewide trauma system plan. Not to take up too much time, but it's vitally important, especially in the rural areas, because trust me, this is my region. This is home for me. Most of the people that you're talking about having been part of these communities and coming to the table to talk about is much like yourself and Dr. Register. They're already wearing about 12 different hats for their different agencies and entities. And I know y'all know that.
15 go.
So as we add more committee structures and try to revamp the RTAC and such as that, understand that the participation from those entities is going to be hinged usually on one person that's already wearing a million hats.
Sure.
And so just think about it. I don't have the answer because trust me, I'm wearing just as many hats as a lot of other people. Just think about that in our structure as we're developing it, because yeah, we can have a meeting and they might call into the meeting, but they're probably on 2 other meetings at the same time.
Very true,
Yeah.
very true. All right.
I just wanted to add on to what April was saying. I have a dual faculty appointment with the College of Nursing as well. And I think one of the things that I see frequently, and I'll be really curious to see if those involved in nursing education in the rural community see the same thing. It's almost as if bedside nursing has a negative connotation or attachment to it. Like if, and I see my fellow professors doing the same thing. It's almost like, well, if you can't cut it, I guess you could be a bedside nurse. They don't say that, but I think the emphasis on bedside nursing and the importance of providing bedside care, we really do need a revitalization campaign on the importance of a good bedside nurse and the impact good bedside nursing has. Because they all want to go through their program and become nurse practitioners. Not that we don't need nurse practitioners, we do, but you know, we are graduating nurse practitioners who have only had clinical experience bedside care. And then they're gonna come out becoming independent practitioners. And I'm old, I show my age, but to me, that's terrifying. But to the younger generation, they don't think there's anything wrong with that. And so I think one of the things would be to develop a campaign to share why it's important to provide bedside care, how important it is to the patients to have those bedside nurses and what they mean. So
Very
for those of you in the rural areas, are you kind of seeing the same thing?
Well, you know, the statistic that bothers me is the average, I've heard this and somebody can probably correct it, but I've heard that the average AD nurse that graduates works less than 3 years in the bedside. They either get out of nursing completely or they go into some administrative type role. That doesn't even include the ones that are going into advanced practitioner work. And so many of the nursing schools, like you say now, are pushing no bedside experience. And you're right, it's about money. It's about money, and which bothers me a little bit.
And then they're hiring advanced EMTs and paramedics to do the bedside work.
That's right.
They're not able
That's
to
right.
work on the ambulance.
Right, right.
Yeah.
So you know, I mean, going back also to your thing about recruitment, you know, I think we're starting to see the down end of the bubble with the COVID pandemic effect on travelers. That's been a real problem, you know, is you pay a traveler more than you pay your regular staff. Staff gets fed up, they walk out the door.
They go for an agency and they come back and work in your hospital at an agency rate right next to the people they worked
Right,
with
right. So
before.
it just it creates a horrible process. So, okay, going on. Develop standards regarding qualifications and educational requirements for providers caring for injured patients in the rural environment. I mean, I think we have basic standards already to begin with in the state, or we wouldn't have a state system to develop already. But I think some of this also falls under several things that Courtney Twilliger has talked about. He's still, Courtney's still here. One thing is about giving, you know, with our EMS crews out there in the state, being able to get blood and transport. Several other more advanced qualifications that aren't, that not necessarily, it's just not because there's not a paramedic on the truck. It depends on the county and their practice acts that they have, or their standards that they have, and the ambulance services that are out there have their standards. So how do we as a state go about pushing that to have, being able to do some of the advanced things that Courtney's talked about in some of the meetings across statewide? How do we do that? Yes,
Yes, Greg, the question we got to answer before that is, what's the turnover in the EMS population? Is it similar to the nursing, where if your paramedics are only there, your BLS technician is only there for 2 years, it doesn't make a lot of sense to invest, but I don't know, Courtney, do you have any idea? You guys, the state have any idea?
I will give you some anecdotal. I got into EMS 17 years ago, okay? And at the time that I was graduating paramedic school, the average thought process was the average paramedic will stay for 7 years. And that was 17 years ago. I can tell you it's way less than that. It's way less than that now. We have some advanced EMTs that want to move on to become paramedics. Some don't. They have no desire to become paramedics, but the paramedics that are still on the truck now are either new or getting close to retirement age. There's a very big gap of age between the seasoned ones that have been there a while and the babies.
Where do they go if they're leaving the paramedic field? Do they become a flight
They
nurse
go
or?
to become nurses. I left the ground and went to become a flight paramedic personally, and then left that and went back to the ground before I came to work for the state. I'm not clinical anymore. But at the same time, they go to become nurses. Some of them are going to PA school, but at a very small rate. And then a lot of them are just getting out of the profession as a whole. Yeah. They're going to do something else. I was comparing EMS to what April was saying about nurses when she started talking about the pensions and the ratios and stuff like that. And some of that stuff we can't solve, but when you've got folks that are coming in the door and we all had the hopes and dreams that we just want to help people, you know, but when they came in the door, they saw that, then they started running the calls, they started working the 24-hour shifts, and the typical 24-hour shift now in rural Georgia is a lot different than it was when Courtney started, you know. The number of calls and the distance that you have to travel, along with several other key factors, just is not a desirable profession to stay in unless you genuinely have a passion for it. And so they're moving on to other things, whether it be in the healthcare profession or they move into other private sector type jobs or other careers. But to answer that initial question, 17 years ago, it was expected to be 7 years. I will tell you now, most paramedics that are coming in the door will stay probably 3.
Yep.
And I
Just gotta
think
figure out
through that GDAC website, aren't they gonna be able to figure out by cross-referencing to figure out which, because they can with the nursing database, figure out paramedics who go on to become nurses then. So the future state, they should be able to give you some of that information to see who's leaving through that door, you know, that will be That'll be helpful.
They're also employing a lot more paramedics in the emergency room. They're working less hours. They're working 12-hour shifts. They're making more money. And they're coming off the truck, which is killing EMS, but it's also helping the ERs.
I'm trying to follow along in the big document to give some context around some of this stuff. So for the, they talk about what looks like relevant to this, we're on number 3, the standard qualifications and educational requirements, is that there's inconsistent training and capabilities for severely injured patients across, it says level 4, but I'm assuming it's probably also EMS because there's none other context in that. But so I'm just curious, like, it does seem like requirements, protocols, whatever, are very locally driven. So, and Courtney, you could comment on this too, like for the blood administration piece, there's no requirement for that. So, you know, if we're looking at those patients with really long transport times, like those people probably need to have that training, right? Because there's a high likelihood they may be given blood. It may only be once a year or twice a year or something, but it still might happen. So is there a push towards local or more statewide protocols or expanded or requirements and how do we compare? You guys are in the best seat to comment. How do we compare nationally to what other people are doing?
The first part of your question, you're talking about, where are we as far as setting a minimum standard or?
I know you have a minimum standard, but I think our minimum standard's a little bit less than what, you know, maybe the
It's
scope
actually
is.
more than the national scope of practice.
Okay, well, that's good to know then.
It is more than the national scope of practice, and paramedics now can maintain blood on the transfer. It's a post-licensure skill to initiate blood, and any service can obtain that post-licensure skill and get approved to initiate blood in the field. But just very few services do. I don't know the exact number.
Right, it's not so much, and I don't know the top number off the top of my head. I would say it's probably 6 agencies right now, not counting the air services that are carrying blood. And most of them are in Region 2's area because they were part of that pilot. But we do have a couple of agencies outside of Region 2 that are part of the blood program, that they're carrying blood or they've received the approval to do that. And it's not so much that we don't have the ability, because they do now. The issue is a lot more on the service level and the medical director level. Not so much that the medical director doesn't want to give him blood. It's not so much that the paramedics don't want to give blood or the service director doesn't want them to give blood. If I'm gonna give blood once a year, do I really want to invest upwards of $20,000 to carry blood on the truck?
Right.
It's very cost prohibitive. And there's no reimbursement for that. So that's why you haven't seen this major push. Region 2, and I'll speak to the folks in here for Region 2. With Northeast Georgia Medical Center being kind of that hub that helped push that along with their pilot and stuff, a lot of those costs were deferred back to the hospital and part of that regional program that they had. But you look at this region, Region 8, you're talking about 10,000 square miles, a little over 10,000 square miles that you want to have blood on ambulances. And our only major centers, our trauma centers, are Archbold, SGMC now, and then Phoebe's hoping to come online as a trauma center soon. For us to create a coordinated regional system, well, not to discount Chris, but sorry. To create that regional system, you're talking about a hospital working, each of those 4 hospitals trying to work in tandem.
Right.
With 27 counties, you're looking at 42 agencies in the 27 county area. Are y'all willing to take on the brunt of the cost?
But it doesn't have to be that. It doesn't have to be done by that.
No, it doesn't, but
Yeah.
it's more cost prohibitive and I don't want to say demographics, but the area is going to determine whether or not that can be done. And that's just specific to the blood.
So I disagree with what conversation is, because that's not what I've been pushing. I recognize the difficulty in low volume services carrying blood is almost impossible. I'll admit that. But it's not impossible for an EMS agency to pick up a critical patient at a hospital that has blood, and then to give them an additional unit or 2 of blood to be infused and read. That is not rocket science. And that had been legal up until they did the post licensure skills. So to do that legally, was that it just got to go through a post licensure skill training. We did that in the manual, and I think at this point, about 17 services in the state did that. So if you're not one of those 17 in your community, and the medic backs up there, and you know that they need more blood during the hour transport or someplace else, and the medic's got two choices. They can tell you, no, I'm not gonna do that because I don't have the license for it. Or they say, sure, I'll do that and take the risk of my license. And that is, one, it's not rocket science. You know, it is just not. And two, it would be so simple for the state to develop business training. There's a protocol, there's a slide set, to do all the dynamics online, and the mechanics of doing it is not difficult at all. So I don't think we've done a good enough job putting that out there. And quite frankly, I think it ought to be a required skill, either through initial training and backing it up by ensuring that everybody that's got a license. And that is, in my opinion, the AMT ought to be able to do that. The biggest issue is the mechanics of doing it and looking for the, the untoward effects of a reaction. So it's not rocket science.
And I agree. And maybe this is just because I've been very still new to the game, and sometimes I feel my questions are naive, but just to clarify, it sounds to me, correct me if I'm wrong, but it sounds to me like really the biggest hurdle in having blood on ambulances is not the clinical training, it's more who's gonna bear the burden of cost. So if there's not one, like Region 5 has Navicent, well, that's my main level 1 that I transfer patients to, but they're not in my region. And every hospital has a different blood bank company that, like, we use One Blood. A lot of others use Red Cross, but there's a cost difference and there's an availability difference. And that's something my hospital has had to look at, the financial burden and all the numbers that go into that. So, but if our end goal is how can we take the best care of traumatically injured patients in our area, but no one is able to bear the financial burden to be that one hub that's responsible for the cost of wasted blood products, because we thankfully, live in an area that, patients that are hemorrhaging, and if they don't get blood within those first 15 minutes on the truck before they can get to the closest ER, they're gonna die. But it happens often enough because of the large landscape we're in a rural area. So if we can figure out a way to address the financial, who's gonna bear the financial burden for carrying blood for a region? Is there a way from a state perspective, whether it's the GTC or the state office, or is there a way we can envision financing that without it falling on an individual hospital per se? Like, how can we solve that problem of who's gonna pay for the blood? Because it sounds to me like that's the problem, is who's gonna pay for the blood. So if we can fix that problem, then maybe we can actually make this happen.
I don't think we talked about that under number 1, that first little bullet, funding for the rural trauma system. This would fall into that.
Let's come back. Well, yeah, I mean, you just have to, don't limit yourself by funding. Just say what you need and we will figure that part out. But I was gonna send the link out to folks, and I saw Jesse's hand raised because I want to hear her address that, but there's several other programs across the country, and San Antonio is one of them. You guys may have based your program on that, and they just started with 150,000 grants, so we're not talking about a ton of funding, yeah.
Yeah, and we did actually base our program a lot off San Antonio's. There's some differences though in how they're able to get their blood products, because they basically have a walking blood bank, and so with some military bases and whatnot out there. But I was just gonna say, I think one thing, as we've talked about our program at several meetings and whatnot, but we had to look at, originally we wanted to do whole blood. We know that's the best thing, but as far as availability, cost, etc., made enough sense. So what we did, based on some research done by Dr. Krill, our medical lead on the project, we went with plasma.
plasma's $50 a unit. And I think that, you know, we have, like you mentioned, I mean, because we have an exchange process, the medics bring it back when it's 7 days from expiration, so we can put it back into our inventory at the hospital, and we can bill the patient if the patient comes to our hospital. So, you know, in a region like ours, that's easy, but from these other regions, I don't know that, you know, I was just thinking, I don't know where the air bases are in the areas. I don't know where one central point could be, but I think if we maybe not focus on protection with whole blood or packed cells and maybe think about plasma, your cost can be much lower. And then the startup cost for the equipment, you know, we were fortunate to get a lot of that donated because it was a pilot, but it's not significant. I mean, it's not, like Liz said, I think $150,000 grant should set the whole state up pretty well, I think, if we could do something like that, but, you know, it's not as significant as we think.
And like you guys did, we could do, we've got air providers here in the room. We've got the air provider coverage across the state. I was impressed when we did our console and we had to submit that map. It looks really good. I mean, we can build a network. This was the whole idea of this, is bringing those people in the room that can talk about it. And we can, at least with a lot less money, probably start it in a smaller pilot like you guys did.
And one of the things, even in our region where we have 4 services participating, we don't want all 13 counties carrying blood because we don't think that's feasible. We don't think they'll use it, but we're looking at mutual aid. Hey, when you're cutting through my county, can you swing? And we've done that.
Right.
And we've had people, you know, meet at the Habersham County Airport to get those medics some blood and whatnot. And so I think we need to be thinking a little bit more creatively than putting blood products on every single truck. It's a ton of logistics to do that. And so I think there's some probably better ideas.
I think the way the San Antonio plan works is they do like a round robin so that it gets used. And Alicia, until you said it, I never realized the cost for you as a trauma center to maintain your platelet supply. I didn't
Right.
realize how cost prohibitive platelets were.
Right.
And we could partner with the cancer centers in the area where
Right.
there's actually
they're
Albany.
all-
I
right.
think you guys have a big
Right.
cancer center. Like,
Yes.
there's a
Right.
way to get this
Right.
done. I think that's a
It's just
win-win for
creative,
everybody.
it's following that, you know, like you said, 7 days, rotating it back into hospital plus, it's gonna be used more frequently. Centers that have associated cancer centers have a whole lot less platelet costs because the cancer center is gonna use more platelets than the trauma center is most likely. You know, so it's a whole lot easier to do those things.
It also allows you to use whole blood, sorry to interject, but that allows you to use whole blood a lot more cost effectively as well, because the shelf life of whole blood is pretty good.
Yeah.
Yeah.
And you can rotate that through the trauma
Sure,
centers.
sure.
But
Yeah.
it is $550 versus 50 per, I mean,
For
so,
the giving of it, yes.
yeah,
Right.
I'm more for the cost.
Yeah,
too.
but the shelf life of
The
it
shelf life's
is
better.
great, and so it allows sort of a long.
I think our plasma's is it 21 days, I want to say.
You've got
And
2
that's
weeks to have it on a
we
truck.
use
and you
liquid
go give
plasma,
it
not
back.
fresh
I was
frozen,
gonna-
so.
What about the freeze-dried plasma?
And there's some other alternatives, and of course,
Okay,
from
just curious
what we
about that
heard
too, yeah,
earlier,
Option.
It's not
earlier, our
everything.
summer
Yeah.
keynote speech at that time was on that.
To speak to speak to Courtney's concern, you know, and I know we continue the conversation about initiating blood on the trucks and having it and the viability and the feasibility of that, but, you know, Courtney made a good point about I'm going to pick up this patient and transfer them an hour and a half, and I'm gonna need to hang more blood. We have processes in place for that. It's just important to understand from our perspective, and I'm speaking out of turn. I didn't clear this with Michael, so please understand, I'm speaking on behalf of DPH, but not at the same time. From our perspective, it's important to remember that our role, we certainly want to be helpful to EMS, and we want to boost EMS, and we want to take care of the patients and do all that we can, but our primary role with the state office is to protect the public from EMS. And I know that sounds harsh, but it's not intended to be. So when we have these guidelines and these rules and regulations, is to keep that EMTB, the service that says, you know, I can't staff my trucks with paramedics and advanced EMTs today, and the only way that we're going to get patient A from point A to point B is to run 2 EMTs. That's the better option than not having the truck available at all. And so that's kind of what we're faced with. And then when we back up to the doors of the hospital and says, this patient needs more blood on the way. Well, now we have 2 minimally trained, they meet the standard of being able to run the ambulance with the patient in the back. We set a standard with the post-licensure skills saying that, okay, you go through this training because it is outside the scope of practice for paramedics to do. We have a heartburn of saying, okay, yes, anybody that's on the ambulance can do it. And we can't just say, okay, and I completely agree with Courtney. It is certainly not a difficult skill. It's not rocket science, but at the same time, we have to have a standard of who can and who cannot do it so that we are making sure that we take care of the public and ensure that who's showing up can physically and mentally do the job.
Daniel, working with a service that periodically has issues with staffing, there's another role for mutual aid agreements and pre-planning.
I agree.
And, expect that. You need to move the patient. All you're gonna have is that less acute, I guess you would say 911 service that got 2 EMTs. Build your mutual aid agreement and put your respiratory therapy on as well. I know you're robbing Peter to pay Paul, but do you need that bed? Do you need that person? I mean, we during COVID, we were borrowing BiPAP machines from hospitals to move patients,
I agree.
so that we could get them from A to B. We have to have those processes in place. Yeah, that means they don't have that BiPAP, but they have that bed and they'll get that BiPAP back. You won't have your nurse, you won't have your respiratory therapist, but you'll get them back.
Mhm.
And your patient will get where they need to go. So I actually do work for a service that does have those agreements with their hospitals. So when they are having to run a BLS, I know it's a misnomer, a BLS truck, I mean, I actually read a call the other day and got carded. Do you have your PALS card? Of course, the patient was already on the stretcher, so it's kind of like, well, you're gonna take it back, but anyway. But at least they were asking, at least they knew that sometimes they were getting those EMT providers, and they wanted to make sure that that patient was appropriately staffed to be taken care of. Which, by the way, was hard to tap.
Right, so-
It's all good, but I'm saying,
Yeah,
there's another role, we gotta think outside the box.
right. Let me tie this back in, just let me ask for any other comment related to funding for the rural trauma system, emphasizing rural aspects of EMS and trauma hospitals. Liz, let me ask you a hypothetical question. What would it cost for us to fund the pipe dream of trauma systems in Georgia? And she's ignoring.
On the entire
$100
$100 million per year?
Well, I think we're looking at closer to 160 million, if you're looking at it, based on the trauma system stabilization plan, and that's just from the readiness cost. So if you're looking at just readiness cost and not uncompensated care costs, we're hoping to achieve a 50% of the readiness cost at $80 million. So if you want to do 100% of rent, that's 160 million of the trauma systems readiness cost, not uncompensated.
The context, the
What?
context, existing system or what?
That's our existing system right now.
the context in that full report, we don't have, I mean, they still agree that we don't have enough readiness support, but we do not have a structured startup grant. So I mean, I know a couple, like Phoebe got, Northeast Georgia got a startup grant, but it was kind of like a dart. It's not evident. We didn't look at anything like readiness to say, so we need to know, and maybe that is a matter of getting some folks who could be prospective level 3s and then prospective level 4s and saying, what's a beefy enough grant to like get you in this game? Knowing that money doesn't fix everything, but we do need to know what that amount is.
What was the reason for the question, Greg? I forgot.
I'm just asking so that everybody in the room would know
Yeah,
what that figure is and where we are, based on what's going on right now.
that's the requirements today. The minute we add a level 2 or a level 3 comes on board, that number goes up, right? So.
And so, to touch on that, I was having lunch with somebody the other day and I felt like we had, some good, brainstormings, but the rural centers, like a rural level 3 is a very differently resourced facility than an urban level 3. And the thought is, could we have a completely separate pot of funding that goes to the rural centers. They have completely different resources, completely different needs, and could it be supported by somebody like the Office of Rural Health with different kind of grants? And not, I mean, not like for a specific level, but if you found an alternative mechanism to fund rural, because I know it's a little bit easier to get money when you attach rural to something. Could we have a whole different pot that would give money that the Trauma Commission gets through its current mechanisms, more money to give to your non-rural centers? So it would actually make the pie bigger.
I guess I don't understand the question, because there's a clear documentation of what resources are required to obtain a level 3 designation. So tell me the difference, obviously, because I come from an urban center, or if you consider Savannah urban, help me understand the challenges that a rural level 3 would have from a resource standpoint compared to a urban level 3. They still need the what?
For example, how many ORs do you have?
4.
4. Okay. Recently just did a level 3. They have 16 ORs. They're running 14 of the 16 daily.
Okay.
Though those are not created equal.
I see that as a level 3 that could
Should-
probably be a level 2, but just doesn't wanna like commit to that level.
I think
Of
it's a
call.
volume issue, the readiness the
It's-
base readiness
Right.
should be the same.
It's
Right.
the same, right, yeah.
At 0
It-
or
it-
500.
right.
but
Because
Your
it depends on your
utilization
other-
of resources are
It
based
depends
on
on your other
volume.
it
Correct.
depends on your other resource, other things you've got there.
Cause
You
you'll.
have cancer
consume
center,
more
you have this,
resources.
you have that, you know, and so all those things can build a
And the
system like.
uncompensated care, because right now we don't measure uncompensated care and
Yeah.
pay for level 3s and 4s, so that's another big part
Right.
of the funding gap that's missing.
Right. You know, I think one of the things years ago was, you know, and you had people looking at it from a standpoint of the funds that we did give out. You know, the bigger, you know, the big level 3 versus the small level 2. We're like, well, you know, why aren't we getting as much money as them? Because we have just as many patients that show up
Maybe
in a registry, or maybe even more. Well, you're not providing the readiness that a level 2 requires. So I mean, all, you know, when it comes into play, it's gonna be very big. So each one of them is a little bit different. And then you have certificate of need related issues that are totally out of the scope of this discussion here. I mean, so, you know, we're still a certificate of need state. All right, so let's go on.
So I know Liz wants to come back to what are we doing for each bullet point, right, Liz? And that way
Well, do we
kinda
wanna try to come up with some, like, what is the next step, or just kind of notes and percolate on it for a
Sure.
minute?
So like the funding, I'm not sure we landed on anything there.
The
Unless you wanted to bring up the readiness article and the funds there, and we allocate that we need money that was found in the readiness article.
yeah, I
Can we
mean.
start there?
Yeah, I think according to the full context in the document is we don't have a startup grant process. We need to attack that. I don't know what it takes to start up in the rural environment. So we have addressed the one item where they definitely hammered us for the significant disparity in the amount of funding that goes to urban centers versus rural centers. But again, those were stipend amounts and we just doubled them. It's not based
No,
on.
exactly right.
Yeah, I think, maybe, I know Katie left, but you know, we have the spreadsheet that we hope never gets lost, Dr. Maderas, because we'll be in trouble if the spreadsheet gets lost. But, it basically takes the pot of money, it sets the level 1s as the baseline, and then everybody else gets a different slice of the pie, but 3s and 4s have always been a stipend, so maybe one of the recommendations needs to be for the budget committee to look at an actual funding formula for 3s and 4s instead of just the stipend. Maybe it's some percentage or something a little bit. So we're not just saying, we don't just keep adding to your, so that,
Right.
and
I think
then,
that's the answer, I think. We just gotta figure out what that formula looks like. But yes, I think that's the answer.
And the
the startup grant, and could the startup grant be like a percent of your 1-year readiness? So for example, a level 3, because, and you're feeling this pain more than anybody, right? You can't attract people to your trauma center when you're not a trauma center already. It's
And,
hard.
you know, exactly, and on top of that, we're considered rural, so you know, you have these young people getting out of school, their wives are wanting to be in fancy places and have shopping and all that, and it's just, it's really difficult. It's very difficult.
Yeah, sure.
Yeah, and
So,
that's always been a problem with rural versus urban.
Yeah.
It's gonna be a problem,
Yeah.
you know, it takes
Yeah.
a certain person,
correct,
you know, and it's just a different, you know.
correct.
I could probably take one of the Grady staff members, okay? Invite you down, show you something that you're uniquely
Yeah.
interested in.
Me too,
you
I
know,
could too.
Tennis or golf or, you know, bird hunting or something. I could find that thing and I could tweak it just enough
Me too.
to attract them there. That's where you're gonna have to use your own intuition and your own marketing department.
Exactly.
That's something that we can't handle in this, you know.
But I
Um,
could, I mean, I wouldn't do that, just for the records, but unless
I
they.
would. I'm
unless
not
they
above
call me
that.
First, you know.
I'll bring you up, I'll bring somebody down.
All free games.
All right.
The evaluation of the rural
Hold
trauma, the
Before
second one,
we digress here,
I got
the
it.
second one, the
Yes.
identifying the gaps, you were talking about geo mapping and trying
Yes.
to, okay, so that signature. And recruitment and retention is the legislative committee.
wait
and
for
study
their report and then ultimately readdress that.
I
And
think that, the evaluation of the capacity is also the survey that we're doing. And we did, April and I had a follow-up call with the ACS where they're gonna have calls with us now quarterly, at least so we have something to answer to for our progress. And we asked them for help with this. We were like, this is somebody's PhD research project,
Yeah.
a comprehensive rural assessment. So I mean, we'll at least get a little window with the initial survey and then maybe we can come back with something.
All right, so a couple other points that we've already talked about. Number 7 was reevaluate distribution of existing and future funds to better support rural trauma centers. We really kind of dovetailed into the first part. We kind of answered that one there. One of the other things I'll touch on real quick, and then go on to Dr. Register. Develop a mentor program for the development and maturation of a rural trauma facility, focusing on the trauma program manager and process improvement. We're currently doing that now. We've requested that the level 4s have a PI plan in place. One of the things that I really want to do is follow up with that actively during our quarterly meetings and utilize the committee itself for following up with each one of those level 4 centers and make sure that's done within a year, so that we have that and we can turn that over to the state as a project that the level 3s and 4s have done. The mentor program is actually being addressed by the GTCE, and they're working on that actively. I think, you know, we've got enough stuff I think I'm trying to handle through the committee itself. I'd like to maintain the GTCE input in that and let them keep addressing that thing and basically leverage their assistance in handling that problem. And I'll keep one less problem off our plate.
Do we need to,
We'll be happy to participate as centers, but you may be called upon to do that.
I know everybody's so exhausted and has so much to do in their day jobs and volunteerism is challenging right now. So do we need to like entice with a grant opportunity for someone to oversee like a mentorship? I just feel like it's maybe
Well, we could, I
a
mean-
little bit loose and it's not necessarily structured.
I seem like, well, I think we need a structured plan that needs to be brought to us at some point. And then hopefully that's what the GTCE is gonna do. If you wanna throw money at the problem, I mean, I don't think it's a problem. I think it's trying to build a relationship. You know, it's one of the interesting things is that, I'll be honest with you in the crowd, you know, it's funny, when I first started doing this several years ago, I was scared to death of Dr. Dunn. I mean, he just, I didn't understand, I mean, I thought, I looked at him as this guy I had so much respect for. I was scared to death of, but then also when finding out that he developed a relationship with me, it wasn't me with him, that it actually opened me up to him. And I realized he was a resource I could talk with very honestly about things. And I think the same thing with dealing with the Grady personnel, since my son had rotated there as an intern. It's been very easy to talk with them because they understand that I am not them, but I have my own problems and they can help me out with their knowledge. And so I think it's really, all of us got into this from a medical standpoint because partly what we like to do is we like to teach, we like to talk, we like to tell our stories. And that's where I think we need to just leverage that ability that we have to do that without really pushing a fund for it, I think, at this point. Yes, ma'am.
I just have a question for Liz and Gina and folks who've been around a while. Do we still do the thing that we used to do like a few times a year where we went through all the like Georgia requirements and everything? We used to do them in person, then I think they changed to virtual. We still do that? That's question one, and then I have. You know what I'm talking about?
You mean standards or?
Because we are all Jesse, shake our brains a little bit.
About the orientation of when data is due and invoicing.
Yeah.
Oh, yeah.
For new program managers?
Yes.
Yeah, we
And I
did
think
it.
was ran by the Office of EMS and T.
Partnership.
We do it together, yeah, we did do it, but we just did it for new centers, cause the old people complained, not looking at anybody, but basically.
We should have a year for the TPMs and then, and rotate maybe, you know, the people teaching that amongst all the other TPMs.
Yes.
Make that potentially a PVP that you need to do one a year or something like that.
So
And then that
Rob
could
had
be your-
suggested that about having the PVP be, your mentorship sort of responsibilities for the level ones be tied to being paired with somebody and again, having that structure in there to say what you, yeah.
And I think that's our responsibility as a level one or as a level two, is that we should be helping our level threes and fours to develop their PI processes. And I see that as our role as level ones. And I know, I'm sure Jesse and Dr. Minnie, we're all on the same page when it comes to that. And I've always really worked hard with my referral centers to make sure we're helping them develop.
And I think there's also a lot to learn, like from both sides.
Yes.
Like you have solutions to problems that I don't have to create that solution, but when I hear your solution, I'm like, man, that's a great idea. You know, and so it goes both ways. And I think it just makes the whole system richer.
Should we pair level ones with twos and threes and twos with twos? So should be a shared PVP requirement? Typically the ones and twos, I mean, the twos should be able to provide the mentorship too, right? That gives us probably enough to match up one-to-one each.
I'm gonna speak up as a three on that, just because having worked in Tallahassee was a level two and then worked in a three. The processes and the resources are so completely different. If we do that, there's got to be an awareness on both sides. You know, if I have a level one saying, why aren't you doing this 45-page report? Well, because I'm wearing 4 hats and I don't have time for that. So I think we need to figure that out and work together.
Kelly, I think like when we're talking about mentorship though, I don't think that needs to look like, why aren't you doing something? I think it needs to be like, hey, be my buddy this year. Let me hang with you at the meetings. Let's be almost develop a relationship, not so much as, I don't know. I mean, I see what you're saying, because I've been on some of the calls where it's like, let's pair the threes with the threes, and I'm indifferent. I don't know, but I think it just needs to be seasoned TPMs with new ones. Whether what level
It's
you're
not
at.
necessarily the
that.
level
I
it's
agree with
the
that.
building.
And level specific, honestly, because someone from a 1 or a 2 has no idea what a 4 should be doing or what a 3 should be doing unless they've done that role previously.
The mentorship goes back and forth,
It does.
because we need to learn that. And I think what Dr. Patterson said is probably resonates to everybody, was that he was intimidated by Dr. Dunn.
Why do we have to keep using it?
What I was gonna say is, everybody in this room is probably intimidated by somebody else in this room, and you feel like they're not approachable. And I'm sure you would say, I would always be available for Dr. Patterson, which we all feel that way, but you don't know what you
Right.
give off.
Right.
Where you feel like, of course I'd help anybody, but then they're like, oh, you know, or you catch that person on a bad day and they don't
Right.
see anything, any relationship building, but as being in an academic level 1 center, I need to know, how can I help you if I don't know what your struggles are?
Right, right.
Like, it's a win-win.
But, you know, is there a way, and it would be nice to see, I mean, you know, I've been so far out of academic medicine, or horrible, you know, intense academic medicine, I would feel lost walking back into another center again, except maybe to visit a patient. But it would be nice to be able to have that, just like the military does, in bringing back their people, you know, that have so much field experience and then they come back to the States and they don't have experience anymore. Put them into another place. See, you know, not you didn't necessarily give me a job in that place. I'm just saying, let me come up there and see how your day-to-day works. You know, let me see how you capture your charges or your, you know, talk with your billing people, talk with your business people, talk with see how you run your blood bank, just see how some things go. Not like a formal visit. Don't try to show me off anything. Just let me hang out with you for a little while and see how things go. How do you handle this problem?
I'm gonna come back and be a resident again?
No, it didn't.
Dr. Patterson was a resident when I was a ICU nurse.
But you know, one of the thing I always remember was going to what we used to call DNP rounds, after rounds every day, where we were documenting, and it dumbfounded. That's where I learned about coding. You know, I didn't know what a CPT code was when I was a resident until I was probably a third year or fourth year. And it was on your service that I learned how to do those things, which intertwined into my later life as being a private practice physician. I had to learn that stuff. I know it pretty well now because it's my business to know it.
Yeah.
But those are the things that you know, how do you deal with residents? Because we do have some residents. How do you deal with this problem? What do you allow them to do? What do you do this? How do you mentor them in this case? It would help me in multiple different ways. But at the same time, if you've got a minute to come down and see what I do, to give me some advice, you know, your trauma bay looks like crap. It's too small. You need to give me some leverage with my own administration to do something to help me out. That's where the mentor system would come from.
So, just one thing that, so I came from a level 1 trauma center many years ago. And it was a big receiving hospital, lots of trauma, region 9. And then I transitioned to a level 4 sending hospital, very rural. It is a complete different aspect. I mean, I'm starting from 0, where I had so many resources to no resources, writing all of my plans, starting over, working with EMS, trying to build community outreach, wearing multiple hats. So it is real different in a rural community. So I'm looking to reach out to my cohorts to help me.
Now, let me ask you a question. When you did that, have you not leveraged some of your previous contacts? You called them and asked them questions, right?
In my room right now, yes.
Yeah, so you've instituted your own mentorship program by yourself. We're just talking probably more of a formalized mentorship program. So we've got some definite connections and some of the barriers, again, going back to that one barrier that we had, that was broken down. I didn't see him as a human. I saw him as a level 1. I saw him as a level 1. I saw him as this. I saw him as this pedestal person that I had, back when I saw my attendings as gods, that they were so smart and they could do things. But yet when they started to show me those things.
Now you can keep talking. Pedestal, so smart, I like that.
But you have to break down those barriers first, and that's what this is all about, is we have too much, it's like the kinetic energy of an equation. You got to go over the energy required to do it. That's what we're breaking down, is that energy. We're stopping the inertia that we have and start moving forward at this point.
And I like what you said, this isn't an incredible time sink. We don't have to develop a complex curriculum with
No.
knowledge, skills, and objectives. We just need to spend time with one,
Right.
right? And pick each other's brain.
Right.
That's where the time sink is just the time, but it provides immediate benefit.
Right.
Because you get your questions answered immediately,
Right.
right?
Right.
Dr. Benjamin.
Two things. One, I would love to come up and spend like a day at Grady. Like I've always kind of just been curious, like, oh, that big hospital off the side of the interstate in Atlanta. But then you've had your hand up for a while. So what did you?
No, I was just saying that I think I think to the comment about, pairing, I think there's a lot to be learned from pairing centers based on their level with experience and not experience. But I do think that there is also a huge benefit to pairing like 1s with 3s or 4s, because we're getting transfers from the 3s and the 4s, and there's a lot of these transfers that, we might be able to either not transfer, save the transport, and actually, set up some sort of system where that person doesn't then have to drive 3 hours to Grady, us evaluate and say, now you can discharge, get your family to drive 3 hours, pick you up and bring you back home. And oh, by the way, you can follow up with us in our clinic in 2 weeks. I mean, So I think that there's a lot that we can, and if I better understood your resources, then,
Right.
and you better understood my resources, I think we could have more, I don't know, I think we could serve our patients better.
Yeah, I think we have some of those relationships with, to me, I have those relationships with other services. I can instantly call some of my colleagues, in particular, one at Emory Midtown, that I refer certain oncologic issues to. And they said, hey, Greg, I just operated on this person. Do you mind checking their drain output, getting a drain amylase and pulling the drain for me if everything's okay? They trust me to manage that issue for them, which is really an honor because they're trusting me to follow up the patient they've done some complex surgery on. But yet it also saves that family who has limited resources and other things. It saves them a lot of time. I can follow a wound for you without any problems. I can follow some certain things without any problems. If you'll just let me, if you'll trust me in that case. I think the other thing that we get into is some billing issues in that case. We need to break down those barriers as well. And that's, we have the ability, it's just a matter of whether we do it or not.
Can you expound on that? I don't know what
Well, I
you
mean, like if you operated on somebody, for, a gallbladder,
Right.
okay, you've got your 90-day global follow-up,
Right,
and you know that a patient's moving, and you're not gonna follow up, and they have a problem, and you want me to take care of it, then technically, I can charge them follow-up fee related to a modifier on your CPT code, and you could follow a reduced modifier. That's a big deal. That takes a lot of cooperation. You may not want to do that.
Yes, right.
But at least we can do some things too. Man, it's built into the system that we can do that. If the bureaucracy's built it in, there's gotta be a way we can do it.
Yeah.
We don't have to overcome new bureaucracy. Yes.
Just to prevent like anybody duplicating work or all of us doing things that we don't know about. There may have been a little snag in our office with the data issues, but the mentorship and the pairing of the centers is something that we have actively been working on since the beginning of the year. When I talk to centers, I've, had this exact discussion with each and every one of them about who their resources are, who they need to contact, who they should go shadow. And so like, I think putting it on paper and maybe putting it in a PVP so that not one particular center is having to do all the work. I think that would be great.
Sure.
But I don't think we all need to be trying to do the same thing in different ways. Just know like it is already being done, but if we need to structurize it or put the performance-based pay on it to make sure that there's equal participation. But it is something that, we have been actively.
Once again, I don't think we have to reinvent the wheel. I mean, like for Region 9, I got 4 or 5 level 4s and a level 3 that I can just reach out to, go visit their shop, have them come down and visit my shop, and then we can have a logical discussion. I really appreciate what Dr. Benjamin said, but because I'm assuming they have I know they don't have my resources, but I don't know what they don't have, right? So I can't, everybody's a goofball until you actually sit down and talk to them, right? Face to face, or they're afraid of you, one of the two.
You brought it up.
So I think that's on us. That's on the level 1s and level 2s to reach out to the level 3s and level 4s and, introduce ourselves and say, hey, listen, what resources do you have? These are what resources I have. Let's work together to try to the benefit of the patient and their family. So I agree with you.
It's no wonder you're intimidating.
Yes.
We
All right.
do have, though, not a lot of experience with our trauma program manager staff. We did find that out recently when we surveyed.
Sure.
A lot of our trauma program managers have less than 5 years of experience, and I think that may be because I think those of us that have done that role or been in that role for a long time know that it probably takes a good 5 years to feel like you have any idea that you feel like you know what you're doing, and I think that may provide some hesitation to like, I'm not ready to mentor somebody. I have no idea what I'm doing, at this point in time. So that may feed into some of that, a little bit of the hesitation, but it also may be great to say, hey, I'm not 100% sure sometimes of what I'm doing. We're learning this together, from that standpoint, and that's okay. Where might we be able to go? Where is some of our strength where are some of our, folks that have some longevity in doing this role, that we might can tap.
Yes, ma'am.
I think too, one thing to take into consideration is it's not necessarily a natural thing to know how to be a mentor or a mentee.
Right.
And one thing that the commission may be able to support is developing a mentor-mentee training session. Because a successful process truly is a structured process with goals and objectives, and it's a win-win on both sides. But it's one thing to, be somebody's friend and take them under their wing. It's another thing if we want to have a real formalized process to be able to move everybody forward together.
Sure.
Understanding what the role is of a mentor and a role of a mentee is something that I don't,
It would help.
it's a recent thing that, in a course I took to learn about that and the structure of it. We hear that word thrown out there all the time, but there is, to be a true mentor mentee, there's a process to it.
All right, I did want to, a couple other things. One is the engage the statewide RTAC system. I think we're talking about doing that. I think we have a process in place to do that, and re-engagement of the RTAC system. It's there. I think I did want to touch on number 6, engage stakeholders and lawmakers to improve funding for rural centers and maximize opportunities for revenue by clarifying rules and regulations of trauma activation billing in the state of Georgia. I mean, I know that's been a topic of discussion with us trying to develop what we're doing at our center. I think this is something we need. I think we need to clarify who's having problems with this across the state and what we need to do, because I don't think we understand where everybody's at this point in this system. Or, the big centers are probably much easier to do it because they may have been used to doing it for a while. I know we've had the Trauma Centers of America come down and give the
And they're
bill.
coming again.
They're
so
coming
we have an
again, so I
action
think
item.
we actually have an action item for that. So I'd like to revisit that and actually maybe even carry out a survey in the state of, especially the 3s and 4s, who's billing for trauma activations and what and are they having problems? If they are billing it, collecting it, and what's going on with that. I think we need to look at across, because I think it's a different problem for the 1s and 2s at this point than it is for the 3s and 4s. Any comments on that? All right, I'm gonna cut it short and give it to my colleague.
Thank you. All right, so this next section, trauma systems, components and integration. I think the common theme to all these points is standardizing trauma care. Whether that's, so point number 1 is standardized trauma care rules order through educational programs. So making sure that we're educating everyone, we're teaching them the same thing. So no matter what hospital you go to, you're gonna get the same trauma care, no matter where you are. I mean, that's the whole reason why ATLS was started, orthopedic surgeon was in a, plane crash with his family and was in middle of nowhere, Nebraska, yeah, one of those Midwestern states, and he's then not knocking the rural area or the rural hospital he went to, but he said, I could have provided better trauma care on the field with just what resources I had than that ER could. This is the system problem. We need to do something about it. And, I think everybody in this room has heard of ATLS, so, just to give a little history, that sounds very familiar to me to what we're trying to do here. So just kind of keep everybody motivated and excited about what we're doing here is I think it's going to end up being something big. And I think 10 years from now, you're going to look back and be like, man, look at how much better our rural trauma care in Georgia is because of these meetings. So, but we got to standardize how we do it in order to get to that end goal. So I feel like point 1 and 2 tie in together. So point 1, the standardized trauma care in rural Georgia through educational programs. And then point 2, improve the capability to manage injured patients in the rural environment by increasing the complement of emergency medicine providers and improving competency of existing providers in rural emergency departments. So kind of breaking that down is kind of wordy, but to me, what those 2 points tied in together say is we need to be better at involving our ER providers in these rural ERs and making sure that we're doing a good job at educating them and educating them all the same way. So I want to open the floor up to discussion and ideas. I'm going to start it off with, we're developing March Pause, which I feel like that's the main goal of March Pause is training everyone that's that's working together as a team and training them together. So EMS, nurses, and then ER providers, whether that's, you know, APPs or physicians, whoever's actually the team members working together to take care of that injured patient in that area. That's who we want to train together with March Pause. So, I mean, kind of where do we want to go? Like, any comments or ideas as far as March Pause or anything else outside of March
Talking level
Pause?
4 trauma centers, is that what we're talking, or we're talking the people that are not in the trauma system?
I think
both.
I think both. I think both the people that aren't in the trauma system themselves, and then a lot of the level 4s where the predominant provider that's gonna be there is an emergency room physician,
Right.
whether they're a formal residency trained person or a family practice doctor who's moonlighting or whatever, or an ophthalmologist that's moonlighting, or whoever that's there. I mean, there's a lot of places out there that have.
The context in the report speaks to inconsistent training and capabilities.
Of any ER.
Rural providers,
right.
yeah.
Of rural providers, not just in the trauma network, okay, great.
Well, I think, and I'm gonna put Cheryl on the spot, but the Trauma Foundation has a grant right now. You want to kind of explain that so people, I think that satisfies this.
Yes, the Trauma Foundation has a rural continuing education program initiative that is ongoing. It is a 4-year grant funded project through which the staffs at the 67 rural hospitals can get training through various programs. Right now, the current year, we're offering TNCC, ENPC, and RTTDC. Next year, we'll be adding ATCN and ATLS, and then also on the table would be PALS, PAIRS, and Cadaver Lab. So yes, this is one way that we're able to help standardize some of the education or training that
And for
is offered.
sustainment, to develop a sustain.
Yes, yes.
Build on-
So we're starting with this as a grant funded program, but one of the things that the foundation plans to continue to do is to make training or educational opportunities available. Right now, we're focusing on the rural facilities, but in the future, there may also be opportunities to fund some for some of the other centers as well.
Again, do we know in Georgia where we are with providers in a lot of these rural emergency rooms that aren't trauma centers, that aren't level 4, even up to the level 4 capability? Do we know what they're utilizing? Do we also realize, I think one of the things that bothers me about this particular topic is that those of you who teach residents know that the worst match specialty last year in the US match was ER medicine. There were over 1,300 spots that went unmatched in the United States for training for ER residents. Where, you know, places like orthopedic surgery and neurosurgery and general surgery were all matched. They got completely matched. You can't find a spot in the United States. You can find an ER residency if you want one real quick.
I think COVID might have had something.
Sure.
What, I was trying to poke Cheryl, that's okay. Part of the grant is to develop a sustainment process within the rural communities. You know, we have TNCC, we have ENPC, we have ATLS. You know, we travel to teach some of these classes, and this grant opportunity was phenomenal, because what we want to do with this now is to identify, and so think about this, everyone who's here in the room, and as you continue with these meetings, brainstorming meetings, physicians and folks who want to be coordinators and instructors in these courses, because it's due on, what is it, C1, do one, I don't know how that goes. You know, whatever she said, and you know, bring me fish, but teach me to fish. It's that kind of thing. Like, we'll come down there and provide these courses and get people started. But the idea is so that a program gets developed in these communities for sustainment, so you can continue to teach the incoming. You know, there's a lot of contracted ER physicians that work in rural communities. And so you may have different people who move in and out. Well, how do we make sure that everybody who's coming through is ATLS? We may train a cadre of folks on one day, and 6 months later, it could be a whole new cadre of folks. So having some permanent folks there who are willing to continue this process, and then hopefully if we're able to, people donate, raise funds, to keep this sustained and ongoing, we can help offset some of these costs, because the courses are expensive, but the idea is just isn't just come sweeping in to teach these classes, but to establish these courses all across the state of Georgia so that they can continue on.
And then, one of the things that, I also want to mention, because you all might not know this as well, right now, yes, we have, courses and they're just being offered for learners, but as we identify those who have instructor potential, we're also going to be funding, instructor courses as well.
Also, I think this ties back into the level 1, 2 mentoring with the hospitals that they're receiving transfers from. I know we've had, someone from the burn center at Grady come down and give burn education to our hospital, and my staff loved it. I mean, they loved it, and it was so helpful. And because we tended to always send our burns to Augusta, which they get great care, but Augusta's 4 hours away. And then you talk about EMS shortages and transfer issues. I mean, that's a long time, you know? And whereas Atlanta's only maybe an hour and a half up 75. So again, it's just establishing these relationships. And I think a lot of that can come through education programs from these higher level centers coming out to the state, helping educate these not just designated centers, but non-designated centers too. So, I think those education programs are very helpful, but I think, correct me if I'm wrong, but the context behind this point from the ACS was having a standardized method of educating and not just kind of multiple different education programs scattered throughout the state. Is that what their point was?
Yeah, and it was specifically to the severely injured patients, so, you know.
So what
is the national standard, like you mentioned? That was the whole point behind ATLS, was some minimum national standard of airway, breathing, circulation, disability, you know, the whole alphabet courses that we take to standardize the process. I think if we identify in Georgia, these are our standards.
What I think where Marsh Pause is really helpful, and we've talked about this, is that, you know, you take HLS every 4 years, right? So depending on your, you know, if you see one really sick patient a year, then you're kind of rusty on that. So at least the March Pause is that scenario-based piece so that they can exercise that with some regularity. And it fills their, what I think will be coming back in the level 4 standards, which is the 8-hour trauma specific. And Regina and I heard a lot about this at the GHA Rural Health. They said they're recruiting providers who do not want to deal with taking ATLS. The NPs don't want to take care of sick trauma patients. They don't want to do the courses and they don't want to take care of the patients.
And unfortunately, you're still gonna take care of
Still
those
gonna stick
traumatically injured patients just with less training.
Right.
If you don't, right, no, exactly, I mean, that's what happens.
Yeah,
So,
that's true.
they're still gonna come to your door, you know, and you're the first one, then that golden hour of trauma to be responsible of giving them the best trauma care, you know, or the most impactful that's gonna make a difference in their prognosis, whether they're gonna live or
Yeah,
die or
couldn't
live
get them
with
to go to the classes.
disability.
Yeah.
But I think, like you said, then how do we then establish, you know, that standard? What is the standard? Is it standard that you start with March Pause and you get, you know, based on volume, you take the, I don't know, that's what you guys have to.
So-
work
Is there a
out, like,
minimum
what is
requirement?
the requirement?
Is there a minimum requirement we can recommend or through the state process of someone working in an ER? You know, would that take a state law being passed at a minimum provider? Would that put too much of a burden on the
He's checking
hospitals?
off some confidence.
Well, it depends if you can provide, if they can get the that requirement for free without having to pay for it.
Right.
So what happened in my facility, so we're level 3, so we have to be ACS verified by 2026 now. So part of being ACS verified is all of our providers, and that includes mid-levels in the ER is ATLS.
Right.
And so we made sure of that, so we got a checklist of who all is current with their ATLS and who's never taken it before. And we made sure that they got ATLS certified. So if I'm not mistaken, now every mid-level and physician in our ER is ATLS. But that wouldn't have happened if we didn't have to be ACS verified. And so it was because ACS set the standard that then, yeah, so So I guess if ACS's standard is saying everyone that is gonna take care and be in charge of the care provided to a trauma patient in your ER must go through ATLS, then I guess that's the standard. So then the next step is how do we implement that in Georgia?
And minimum competency is set, I mean, I feel like for trauma centers that have a designation or verification.
Right.
But I mean, yeah, like as a state, I don't think that we can tell a non-designated, someone that doesn't, a hospital that we don't regulate, that would have to be like, I think a DCH thing, the Department of Community Health, and like the actual like hospital size, not.
Standardize the messaging. We have to standardize the messaging, but we have to realize that there's gonna be a common thread that needs to flow throughout every one of these courses that we need to make sure we're delivering. But we have different levels of resources, competencies, but we do need to standardize the messaging so that all these programs dovetail into together. Does that make sense? Okay, the way you teach Stop the Bleed to the 1.5 hour course is gonna be different from the DECC course. And you're stepping it up a level. I mean, same thing with ALS, ACLS, BLS. We got to kind of sort of figure out where those common threads so that everything's dovetailed together. And I think using the process similar to what your Office of EMS is using. Right now, you're not developing your guidelines, but you do have model guidelines that you publish and train on. And when you do your QA, QI, you base your QA, your QI, your CPO, that kind of stuff on those model guidelines. Does that make sense? I mean, we've just told our region, yeah, we know you all have different policies, but when we do our RPI, we're looking in terms of that model that is out there. That would make sense. So you publish those common messaging. I don't think you can standardize your course for everybody.
So I guess a action plan for these 2 points could be collaborating with the Office of EMS and Trauma and GTC and making sure that we're aligned with what is our standard. So, because if we're getting our designation through the State Office of EMS and Trauma but our budget through the GTC, then making sure that both parties agree, yes, this is when we're doing site visits, this is what we're looking for in ER providers, who's staffing the ER. Do you have this? What's our minimum standard and what would we like to see? So, and I will say that since we just recently went through an ACS verification visit and dovetailed our site designation visit off of that, I'm very hopeful and excited. Like, I love the direction that we're going. I think we're gonna find that alignment. I really am confident in that, that we're gonna be working together, that we're gonna have the same definitions, the same expectations. So I'm excited about that. I think that's happening. Which that kind of goes to point 8. So we can jump down to that maintain accountability and the designation or redesignation of level 4 trauma centers. Since we actually have you here in the room, do you mind just kind of speaking to that real quick as far as where the status of our designation, like our site visits around the state, especially for the level 4s?
So some of the level 4 have already entered their data here. And I'm very thankful for these level 4s that took on the responsibility to reach out to us, saying, we're soon to expire. What is going to be our redesignation process? And for those that had already expired, had not had visits, part of the redesignation is just getting back in the centers. Gina and Marie doing the data validation visits with these level 4, looking at their data, seeing, no, we don't want to punish the centers for the lack of our presence, for whatever reason that was. So we need to give them adequate time to be prepared for a visit. A new center has a year. I feel like they need at least the full year heads up, they were coming back. And we are reestablishing one by one. I think we have 3 or 4 left, to reestablish that designation, that's not scheduled. But we want them to be successful in the redesignations. You know, no one's been in there, no one has communicated, no one has mentored, or been a resource. So I think it's important that when we do go back, that they're adequately prepared and that they see it as, you know, not punitive. And I don't want to lose centers, de-designate or revoke designations. So we want to adequately prepare them and then be as successful in the process as they can be.
I think it's one of the things that, especially with the level 4s, this is where the mentor program will help out. Number 2, I think this is where we see the benefit of where the Pennsylvania visits, visits and the 5 centers that went through those processes, ultimately, hopefully getting the rest of those centers done within another year or so. To show them what a strong level 4 system looks like, either Texas or Pennsylvania, and what we in Georgia want. I think we're hampered a little bit by the fact that the ACS cut out the level 4s out of the gray book, but hopefully it will be put back in, but we can come up with our own standards. I think we need to come up with those standards ourselves. Minimum state standards that are there, and ultimately what we need to have and that I can quote. I mean, you may have some standards you have, but I can't quote those, you know, so if someone calls me, I don't know what those are because I'm not a level 4. I haven't dealt with them before. And so
Currently it's the 2014, it's the Orange Book.
Right.
So there were some talks, Liz, Gina, helped with. We came up with some desired or recommended guidelines, more so of like what kind of minimal equipment their trauma bay or ER needs to have, but not so much as like a hard requirement. That some surveys went out to poll and see like us just trying to figure out what they have in the first place of, you know, would it even be a reasonable hard requirement? But currently it is the ACS Orange Book for the level 4s. I mean, and if we designate a level 3 or a level 2 that's not pursuing verification, we're still using the gray book. And the entire site visit is mirrored to look just like an ACS visit. Even the chart reviews.
I think the other thing would be, just totally lost my mind there. With the level 4s, the PI process that we talked about earlier, that I think the rural level 3 and level 4 committee needs to make as a project over the next year to make sure that all the level 4s have a PI project in place and help them develop those or whatever they need to do and use the own resources that we have so that we have that process in place. So they won't even have to worry about it. Because that's the biggest thing I worry about is the PI process, no matter if you're a level 3 or a level 4, or in that case, a level 1 or a level 2. You can do your normal stuff. You know how to run the traumas. You know how to deal with the trauma patients. It's the process improvement part that's really the difficult part for, I think, us.
So I think we've been going for a while right now. So if y'all want to take like a 10-minute break, let's just be back here at right at 3 o'clock. And because there's some stuff in this section that I really want to have some good conversation on. I feel like we're kind of all at a freeze right now. So we'll see everybody back 3 o'clock sharp. Thank you.
That's a way to cut the break.
I'd like to be able to call the dogs, so to speak, or call the pigs, or whatever it is. All right. We will get the meeting back to order so we can finish on time, I promise. And thank you for your time. I know it's very valuable, believe me.
So let's start back because everybody else is kind of trickling in from outside. So kind of bullet point 3 and 4, I felt like tied together also, kind of like 1 and 2 tied together. 3 and 4, and really I drew an arrow to bring up 7 to the, so 3, 4, and 7 are the ones that I want to look at next. So improve scene response time by bolstering existing mutual aid agreements and addressing staffing shortages. So that's basically our our pre-hospital, our EMS resources, and that, you know, inter-hospital transfer time. And then, develop a process for rescue stops and accelerated transfer in rural areas. And then 7, develop an inter-facility transfer system sensitive to challenges of rural care. So basically all of that combined to say, what do our EMS colleagues need in order to shorten that time to definitive care for trauma patients?
Do you want the context from the report
Yes, please,
about
that'd
that?
be helpful.
Says currently the strained EMS system has led to delayed scene response times, contributing to preventable morbidity and mortality. Transport difficulty surrounding the critically injured patient is further exacerbated by inconsistent transport and destination practices. I remember them telling us verbally that we did not have protocols whereby patients were brought to level 4s and what that should look like. The lack of clear guidelines for transport from scene to destination contributes to an efficient use of resources within the trauma system. Inefficient use, sorry.
Inefficient.
Sorry.
Inefficient use.
Did I say it? That's my Yankee coming out. Yeah.
Everybody's looking at me.
Anybody?
So I'm not gonna stand up here and pretend like I have all the great ideas how to solve this. I don't think there's any one answer to be able to solve this issue. I think it's gonna be a collaborative effort amongst many different facets, and I think we all.
And to be clear, none of these are easily solvable or they wouldn't.
And there's no any one thing that can solve it. It's gonna be 20 different things coming together with the perfect storm to be able to say, yes, we solved this. Just to kind of, I guess, I'll tackle the best I can, and, you know, the rest of the EMS folks in the room can tag on or rebut or anything like that. But specific to improving the scene response times, if we're talking specific to getting on the scene, whether there's an ambulance available at the time or not, there's absolutely nothing we could do about, and I'm not trying to be negative, about the size of the communities and getting an ambulance there quicker than they already are, unless it's because of the short staffing or because we don't have the appropriate number of ambulances in that area. Unfortunately, it's a bigger picture than like what the fire departments do when they do their ISO standards and stuff like that. They say, okay, well, you got to be within so many road miles of this particular fire station to get this insurance rating. Well, there's money tied to that. So as a result, there's funding that goes in to ensure that you have the operation base as well as vehicles to travel from that. We don't have that in EMS. And so EMS is reimbursed based off of the patient going from the scene to the hospital. That transport is what reimburses that. So when you start trying to upstaff the ambulances, if you've got a county that's 600 square miles, which we have some large counties in South Georgia, if you've got a county that's 600 square miles and that agency is responsible for it, but they're only running 2,000 calls a year, the population may be close to 20,000 people. Well, at what point do we set a standard, say you need this many ambulances in that county? So if they're only running 2,000 calls a year, that can easily be accomplished with 2 or 3 trucks in that county, if you're lucky. 4 calls come out at the same time, now you rely on the mutual aid. Well, mutual aid might be the same size county next door that has to come, and into that 600 square mile county, it might take 45 minutes to get to the patient. So I don't know exactly what the answer to that would be. You know, unless somebody just has a big pot of money that they just want to put a bunch of trucks every so many miles so that they're available. I don't.
Well, then you couldn't staff them. I
Right,
mean,
you
we don't
couldn't
have the
staff
staff to do that, so.
So I don't know what the answer to that would be.
So to tag on to Daniel, my background was I worked with one of the helicopter services. And what we did was we relied heavily on our fire department. The county that I'm in now is a very, very long, narrow county. And we have I-95 going through our east end of the county, and we have a lot of fatalities. We have a lot of wrecks. And it is quicker to almost get a helicopter in to fly in, scene flight that patient to Savannah than it is for my EMS unit to come from the north end of the county, drive down to the south county, pick it up, come back to me, which I'm the closest facility technically, but they're not the closest level 1 trauma center. So what I'm doing is being passionate about pre-hospital is I have been working with the air companies about making sure that I talk to the fire department and we have adequate landing zones. And so that if I do have a scene flight, that I know my scene times are cut in half, and then my chances of getting that patient to a higher level of care, whether it be me, which I can stabilize an airway and then ground transport them, or getting them to Savannah.
I think another issue that's contributing to it that we need to be making sure, I'm sure several of y'all, several of us are, is the throughput through our hospitals. You know, we have people making indirect destination decisions in part because they know if they go to the right place, they're not gonna be able to serve their county as well because they're gonna get stuck there for a period of time. And
So
we
that's-
really gotta work on throughput too.
Yeah, Crystal, that's a good point. The rest, there's another, can I read the next
Yeah,
paragraph
read,
that
yeah.
provides more context? It says, as it stands, there is no incentive for rural facilities to care for trauma patients. Without an established, consistent, and appropriate interfacility transfer system, rural facilities are burdened with patients that would be better served at higher level care. In contrast to this, the EMS system is incentivized to deliver patients to the closest facility without regard to destination status or facility capability. Contributing factors for these decisions include prolonged transfer times to a designated trauma center, longer wall times, and concern that the patient transfers leave a gap in EMS coverage for their community. Accelerated transfer agreements in combination with rescue stops at rural facilities have the potential to stabilize critically injured patients without significantly delaying transfer to definitive care.
There's a couple of different problems here that I see, and one of those is, and we've talked about several of these things in one of the other committees, with the GTC, that's the Trauma Program Directors Committee. If you designate, we don't have a system of designating something as a rescue stop, so that the ambulance crew would stay there and still have that patient, so they own the patient. That's one of the things that's been discussed. They mentioned earlier about staffing ratios. Well, there's an indirect issue of staffing ratios in our hospital, in my hospital in particular, is that we close beds based on staffing. And so when we have closed beds based on staffing on the floor, we hold more patients in the ER. In turn, wall time goes up. So it's all a matter of, there's not one magic solution to any one of our problems. It's all interconnected. And the problem is that each one of them are multiply interconnected to each other. And so that's one problem that we have there, but we're going to get everything from all the other surrounding hospitals, no matter what. And if it's a trauma, we have a zero diversion policy. So they're going to send them anyway at that point. So we're screwing the ambulance services at that point. So I think one of the things that, we've looked at was, again, going back to geo mapping, figuring out where we could put an intermediate rescue ambulance service in each one of the RTACs, or one or two of them, depending on surface area and population areas, and where the trauma centers are in those areas. And so if we're sending an ambulance from Thomas County to Macon, they would stop and possibly meet in Moultrie, the rescue ambulance service, transfer the patient, have blood available in that unit, send them on to Macon. And then that unit's back in the county quicker so they can respond to other calls. I mean, so there's all these other different possibilities that we have out there. But what we need to do is we need to think outside the box completely. One of the other things, one of the neatest things I've seen in the last little bit, and Liz has actually been facilitating an introduction, is a company that's a new company that's starting out, that's using drones to fly medical equipment to the scene of an accident and leveraging first responders that are there. Been done other places. So if you've got an ambulance that's got a 25-mile road, to travel on, when it's 7 miles straight distance, and the drone can get there 4 times faster than they can to drop off an AED, to put on, with a bystander that's trained, putting one on, they can shock the patient, maybe get their heart rate back again. There's all these different things that are out there that we can possibly do. We can transport blood. One of the things that we were talking about, we can transport blood and plasma to a rescue stop through a drone service drop it there, meet the rescue ambulance, they've got blood for that patient, the blood, and the patient hits the truck and then boom, they're off. So it's just a matter of coordination. Problem is, I'm not sure many people want to address the coordination issue. We probably need some type of coordination system for different parts of the state. What if we combined a couple of the RTACs into one region, one super region, and put in a med control in that area, and it directed where everybody went? Anybody gonna go for that?
It's gonna be tough.
Exactly. Exactly. And that's the problem, because they've got a bad taste in their mouth about it. And that, you know, I ran for county commissioner on the one thing you just mentioned a long time ago, 20 years ago. And that was ISO fire ratings. And people didn't understand it when you started putting money to it and started talking to them about their homeowner's insurance. Boy, I got a lot of votes for that stuff. And they had no earthly idea what it was until you told them about it. But there's nothing to do with ambulance services out there.
And I've looked, I've found a bunch of anecdotal things and some research documents that says for a population center of this size, you should have X number of ambulances, but none of those studies that I've found have taken into account land mass and the population as far as how many ambulances. So there's no set standard that I can find, any hard-nosed study that shows that this is the standard you should have. And so it falls back on each individual community to say, this is what we're willing to provide, this is what we can afford. And that's what it comes down to is we can afford to do this.
So is that something that we could work on doing a research project, kind of analyzing that data for the state of Georgia and seeing what is I feel like that's kind of something I've been right now, when we were talking about earlier, you know, as far as staffing ratios, provider ratios, like, what do you mean you have a physician shortage? EMS, you know, so what is, in this case, it would be, what is a safe population to ambulance to truck ratio?
Did you want to base it on population or maybe
Actually,
even based on response time?
Well, I think there's a lot of, so I think if it would be good to look at it, almost have like different map, you know how like you have like the book that's like laminated, color coded, and there's like multiple layers, and so you could look at it like a Venn diagram, and so look at the numbers with multiple different common denominators, and then when you layer them all on top of each other, maybe you might find some patterns. But if you don't look at the data, like if you don't start from somewhere and you're just doing it off of assumptions, then we'll never know. So I think that would be a great project to look at those numbers, like what do we have right now and what's the best practice?
What each community needs. When we talk about the needs assessments and the readiness costs and all that stuff, and then EMS, I'll be honest with you, we truly don't know, because it being an emergency agency, just like the trauma centers are, we don't know. We can look at historical data and say, well, on this particular day, on Tuesdays at 2 a.m., we have this call volume. We can look at historical data, but we can almost predict, but that's not how it falls every time. So having something that looks at, okay, best case scenario, you should have this many ambulances in this size community with this population. It's going to have to take more than just 2 or 3 factors going into that algorithm. I know most of the studies that I was looking at were literally population based, and downtown Atlanta's got a lot more population in 1 square mile than we have in 200 square miles down here.
Yeah, plus there you gotta think about, I read a study, and it was, Dr. Avery Nathan's, where they did on the interfacility transfers, but they did geo mapping to look at the physical,
That's the one.
the
that
location,
center
yes,
did
of
that
all
we're
the, like, mountains versus
Yes.
beach versus traffic. What's the best route for the patient to be transferred? Is it air? Is it ground? Is it? And I think that's something we have to consider here when we're looking at all of rural Georgia and the mountainy, curvy roads versus not.
We are in the process of replicating that. However, we do not actually have locations for the trucks. That is like our barrier, and we're trying to work through that because we are.
Comes down, if you've seen one EMS system, you've seen one EMS system. Absolutely. There's consistency about it. And I've done like Daniel, I've looked at a lot of studies over the years. I've talked to the gurus at the national conferences who wrote standards on data system management. And data system management is a way to look at productivity of ambulance companies, but it does not work in rural Georgia. When one trip of mine may be 6 hours, you know, turnaround time, and I talked to them, they said, well, just use that as 6 calls, and figure it that way. You know, just 5.3. But it comes down to people, and the point here about using the fire services. When the trauma commission started funding first responder training, the rationale was me, Manuel County, 686 square miles. You drive back I-16, you're gonna go through southern Emmanuel County. You're 22 miles from Swainsboro, you're 18, 19 from Twin City. It's gonna take a while to get an ambulance there. You can throw a rock and hit the fire station, volunteer firefighters. So we started training a lot of us first responders so they would go and do those lights. And now most of the people who are getting the grants to the first responder course are using them to teach EMT classes because they're trying to staff their trucks. We lost to me the ability to have a key resource. And the bottom line to me comes in, and I've told people, if you'll fix 2 things in EMS, then all we need to do is fix 2 things. We need to fix the EMS education system. So if a young man or woman gets into the program, they got about a 95% chance of success. It's not rocket scientists. We are not teaching neurosurgeons. Okay. The other thing is we got to figure out a way to pay them for what they know how to do and do. The problem with rural Georgia is the economies of scale just absolutely wrong. You're sitting there for hours and hours and waiting. Okay. That same truck in an urban area, they run 12 calls in that same period of time. 12 times what they charge, which they're not getting paid for much of it, I grant you that. But the bottom line is productivity, and you do not have it in rural Georgia. And quite frankly, if you start trying to staff EMS to be productive, guess what? They're going to be productive. What happens to that guy who needs that ambulance right now? He didn't call for an appointment to get the find it. He just did it on his own. He didn't ask for our permission at all. Now we got to have enough flexibility, if you call it that, inefficiency, if you want to call it that. Got to have enough of that in the system to be able to surge to that, either by having staff people or having a great relationship with volunteer first responders who will get there and do those things, open that airway, stop that bleeding, give that person a little bit more time for that other crew to get there.
I think as far as one of the things that I think, if we want to truly improve response times and scene times and transfer where you're going to and all that, we have to come up with some kind of metric to measure it by and hold people to it. To where it's voluntary for them to participate in, because I don't know that we could mandate and regulate saying that you will take this patient to this hospital. I don't think that's feasible in the state of Georgia, not the way our laws and rules are structured and set up. Georgia's still very much a home rule state. And so we have some county agencies that run their own ambulance service. We have some private agencies that run the zones in counties and stuff, but to be able to come in and say, look, if you pick up patient XYZ with these injuries, you have to go to Archibald or you have to go to Crisp Regional. I don't know that we can require that. But what we can do is we can attach it to something that they want. And this is not going to be something popular. So I'm going to stand here as a paramedic and say this is a personal opinion and not the opinion of the Office of EMS and Trauma. And I'm going to go ahead and say I'm sorry to the EMS folks in here if I step on your toes. But do y'all freely give money to the hospitals just because they're a trauma center? Or do they have to meet some kind of metric to achieve that money?
They have to get
80% of the money's tied for level 1s and 2. There's a pay for performance component for everybody.
So here's my unpopular opinion. Sorry, Courtney and everybody else. If you want EMS to make changes at the local service level, to have the mutual aid agreements that you have in here, to respond to certain, within a certain percentage of times, respond to certain hospitals or do whatever, then you're going to have to, at the local level, start attaching it to something that you're probably already giving them for free.
Yes.
Hey, Daniel, when you were talking about, miles and then population, like calculating trucks, you also have to consider available facilities, like, right? Because even in rural, like I consider Northeast Georgia, y'all are still kind of rural, but you're a bigger center, so your county EMS people wouldn't have to travel as far, whereas other counties have to transfer a lot to larger. So you gotta somehow, when he said that about the 6-hour transfer, you gotta somehow factor that in to the resources when you're deciding how many trucks to staff and how.
Absolutely. Whether it's a transfer or a regular 911 type call where, hey, I need you to come to my house for such and such. Right now in Crisp County, if you look at the size of Crisp County and the 4 trucks that David Edwards has running right here in this county, he can get to most of the areas pretty good. Now, when you get out closer to the lake, it takes a little bit longer to get to. But then you take somebody like, where Jamie saw this.
I was gonna piggyback off of what you just said. I'm the regional director for Region 7. We don't have hospitals in Region 7 unless you're in Columbus, Georgia. Dwayne right here, every time he goes on the call, he is transporting out of his county. He's going to Americus, he's going to Columbus, he's Albany sometimes, and that's how
Average
almost
time
all
on
of my
task, would you
services
agree?
are.
Average time on task for any calls, at least 2 hours?
At least 2
At
hours,
least.
yeah.
So if he
And
has
then
one truck,
imagine-
then they max can do 12 calls a shift.
And then imagine the wall times that they're running into when all of these services happen to get busy at the same time and they all transport from Columbus at the same time. And then you've got Columbus Fire that's busy all the time. So it's a crazy situation. We don't run into the transfer issues that a lot of other regions do. But we have that extended time on task because we don't have local facilities.
There's a lot of layers there. Yes, sir.
I would not disagree with what your concept is, but operationalizing that concept is almost impossible. So Wayne, he's more friendly in the trauma care, although his volume is much less. In Central, in Richmond County, because every one of their traumas goes to a hospital in their community. So although they have a policy to take the level one trauma center, right, that's what they're gonna do anyway. The folks who have the most economic difficulty, won't do that way.
I agree. The current model of the trauma commission giving money to EMS outside the education portion of it is based off of the number of trucks you have in any 911 zone. So with that being said, Dwayne, how many trucks do you have in Sly County that are in your zone?
Average.
Yeah, 1. How many do you have on your license? 3. So at most, he's gonna get 3 trucks worth of funding from the trauma commission. All right. He has different needs than the folks in Richmond County that have 45 trucks, and that's just a mythical number. I don't know. They're not in my region. I don't know exactly how many. Just say they're going to get more money. But currently, it's not tied to the operational needs. Currently, it's just tied to basically the number of trucks you have. I'm not saying change that, whatever. I'm just saying Dwayne has to meet certain benchmarks to get that money. People in Richmond County have to meet certain benchmarks to get that money. And I'm not saying it has to be.
I think you got to the essence of what the ACS has pointed out, though. And again, what we're trying to do is come up with ideas here that it's not anything different than what it is for your center's ACS visit. When they come back, we want to have something. I'm not saying we're trying to fix an issue on a piece of paper, we're trying to figure out like what works for the system, but it's to your point is that we have not differentiated what Dwayne needs that's different from the person in a more populous county. The same $800 per truck doesn't serve you the same way. And we don't have a differentiator for that. We don't. And we probably need to figure that out. And that would help us with that disparity between rural and urban, that we are going to come up with the formula for the 3s and 4s out for the trauma center, but for what we need for the for EMS, for EMS.
Yeah, I mean, I think you have to look at like other factors, like you could study the amount of time, like the average amount of time from injury or onset of illness to definitive care.
Oh my gosh, he's singing, let him sing the song, Gina, the definitive care, the time to ditch to
This is
song. We live that life every day.
Hey.
Yeah.
But I mean, I think that would probably, you know, for the purposes of this, it would, I think, you know, give us an idea on where the real need is, because, you know, if this county has an average time of 45 minutes, for example, that also means because their trucks are tied up, their resources are limited, you know, and it's a chain reaction, you know, that contributes to that long transport time, not just simple geography or a limited number of trucks or whatever.
And we'll never make it perfect for everybody. People people choose for a reason to live outside those areas, so we'll just never be perfect, but hopefully we'll have access to data soon. And we can look at the higher yield patients and say, this is the issue, because I do think we have some inefficient use of our system where we're not getting patients where they should go.
Yes, and there are some chain reactions. I mean, we found those patients that like should have gone on.
Right.
Could have gone on and stopped at a lower level center for
Whatever reason.
for whatever reason, because the truck did not want to go on, you know,
We looked at some cases, and I'm just gonna tell everybody in this room that gutted me. They gutted me. How somebody, I mean, and it was just what you you know, it's not intentional. Somebody didn't get out of bed this morning saying, I'm gonna see how many ways this poor guy can die from being in a car wreck. But it was the classic Swiss cheese effect of PI. Something happened at facility 1. The helicopter, the guy was too heavy for the helicopter. They had to burn off fuel. Oh, then they got distracted and got on another call, so they forgot about him. So then they had to figure out a way to get him to a truck. Oh, then he went to the other facility, got waved off there. And then by the time arrives to the level 1, 6 hours later, goes to the OR and dies, you know? And there's no follow-up. Like, we have to do better than that, you know? I mean, those should be the things that we learn from and figure out.
So I'm just gonna jut in for time because we're supposed to end this at 4 and it's 3:33. Crystal's been trying to say something for like 15 minutes. So what do you?
There's a small piece of puzzle, and like Daniel, and I'm not speaking as a representative of any facility or organization, but I do live in a region that has, I think we have 16 emergency departments that are branched. And sometimes I do shop, don't I? And, you know, it's really helpful to shop sometimes when people are posting their wait times. You already own the data probably for what throughput times are just from your AVLS systems. If we can somehow capture, publish, put it on a dashboard, how long our throughput is taking for these 911 calls. And the market start driving it down. We could maybe take a chunk out of it, because I think the market will drive it down. Because if I see that Jesse can get that ambulance back on the road 10 minutes faster than I could get my ambulances back on the road from my facility, I need to be calling Jessie and figuring out what she's doing and what magical formula she has. Now, we can't do it for all 16 hospitals in our region. I think we could publish it for all the body centers in our region using AVLS data, but how you capture that, how you harness that, and how you define it, but you already own it. You're already paying for it. But I know, but then to your point you wanted me to make, we do have a case study in terms of having a specialized transport team made up of regional volunteers responding to regional hospitals in the midst of COVID that we are looking at potentially emulating in our region by partnering our TAC with our medical reserve corps that we have existing, and you know, we already have a case study. We are in terms of we have road miles, patients traveled, and facilities served in bad times, but there's no reason. We're probably gonna win.
All right. I'll make it quick.
You're good.
Real quick, I'm going with Darrell, but EMS director for Swat County. I'm also the RTAC chair for Region 7. I'm not speaking on behalf of Region 7's RTAC, me as a director. I did like what Dr. Ashley said, we've got to get out of the box. I mean, how we used to do business, throw that out. I also agree with what Portland said, you know, there's things in our regions and statewide, our volunteers, we gotta rely on them. However, one of the things that we see, the volunteers have gone down. Okay, and that's because of the Industrial Revolution. People won't let them off work to go to calls. They can't get off an assembly line when I'm talking to them. But, you know, real quick protocols. Region 7, yesterday we had our first meeting as a whole, and I about fell out. But as a whole region, all the directors come together, and we're working on a regional protocol. That way, if my guys go to Marion County or Webster County, or driving through that county, and they need assistance, they know what's in their truck. They're all working off the same protocols. We know what medications they have. Also, we discussed, you know, come up about pressure. You know, if there are medics that's not comfortable with it, we'll get them trained up and up to speed on whatever's in our protocols that we're working with. Now, Dr. Ashley said something about trucks. Courtney, I know you talk a lot about decompressing hospitals. And that's a major problem. First thing we need to do is educate our medics on triaging patients appropriately. Because not every patient needs to go to the house. Well, that's where the doctor's at. It's 3 o'clock in the morning, your doctor's not gonna be there. We can take you to the closest facility and educate them on that, but also, you know, get medics out of the habit. Well, this closure, I need to get back to service. Yeah, we go to Columbus, we out of service for over 2 hours. In our area, it's like a big wave. You see trucks from Marion County coming to Slot County, Macon County going to Slot County going to Macon County. I like what Doc said, we got to coordinate that. One of the things I don't like is in my office, I have radio, so I hear all radio traffic. You hear a county call from mutual aid. County they call, no truck available. We only got 1 truck in the county. We got 1 truck in the county, but we go to you all the time. And, so need to get over that, but some form of, I ain't gonna say regionalized EMS, but having a matrix where if, like 50 something is our closest hospital, if they get burdened, they can put out the call, hey, we need trucks. And not for patients to go back to the nursing home. We got patients who need to go to Mass. We got patients who need to go to Columbus. Put out a call, there's a boat, send it to them, but have a means to backfill those counties. One of the things we did after COVID, we put a QRV in our truck. And that's my EMS vehicle. So at midnight, our truck's out of service and gone for whatever reason, a call comes in. Instead of calling the neighboring county immediately, I get up, don't close on, I'll go to the call, I'll work the call. And, you know, I'll make the determination, hey, we need the truck here now, or, yeah, I'm gonna sit here with you for an hour and a half before our truck gets back. That's work for us. But I don't see any simple fixes. The director, I do like what he said about the money aspect. We have 3 trucks. Do we need 3 trucks? No, we don't. Reason why we got 3 trucks, because I've had a truck on order for over 2.5 years, waiting on it. All right, Webster County has called, hey, we borrowed a spare. Stewart County has lended numerous counties trucks, so we've kept a truck that we'll send out, hey, our reserves down, y'all got a spare. Here you go, take it. And that's why we've maintained that, because we are a small county. We don't have a big tax base. And I'm telling you now, Sly County, Georgia is not for unfunded mandates at all. Okay, that'll start a war. But I like what he said. The Trauma Commission holds the purse strings. So if you don't want to send that truck to assist Courtney Decompress Hospital, and you don't want to backfill a county because you only got 1 truck in your county, and you're anticipating that you may get a call in the next 2 days, then, hey, that trauma grant money, we need to get it. That's my personal opinion. I'm not speaking on behalf of our team.
It's the longest short speech I've ever heard.
You might pick a rant going home.
Okay, so there were definitely other things that I wanted to touch base in this section, but we didn't get around to, and I think it's okay because not a whole lot of my level 1 colleagues are here anymore. I wanted to talk about telemedicine, but I think we're gonna have to leave that for another conversation another day. But I do think that's gonna be part of the solution too, is keeping trauma patients at the 3-4s, that don't necessarily need to take up EMS resources to be transferred, but unfortunately, the way things are now with liability and all that kind of stuff, we kind of have to transfer, because of the what ifs. But anyway, so what I'm getting, I mean, I think we kind of anticipated this, that there's a lot of need when it comes to EMS and inter-hospital transfers, which we utilize EMS for. So I think just having a separate focus group, you know, for EMS issues would, I mean, it deserves its own meeting is what I'm hearing, you know, that there's a lot of things with EMS. So maybe that's something we can schedule in the upcoming months, you know, weeks, is kind of to have a arena to really focus in on our EMS needs. Because obviously there's a lot of them, you know, and I think the feel I get from the January meeting in Callaway Garden and the same meeting here is finally somebody's listening. Finally, somebody is asking what resources we need. And so it's almost like this overload of information but that means there's a lot we need to do. So we appreciate that. And we, you know, obviously there's a lot for us to work on. All right. So Greg, do you want to touch on the 3rd section?
I think really, in all honesty, with 16 minutes to go, I don't want to open up Pandora's box and start something that we can't finish. Because I do want to get out on time, because I know you have a lot of places to go. But the other thing I did want to touch on at this point was, obviously, there's a lot of passion about this. I think we've started the dialogue. I think we need to continue the dialogue. The work groups out there, so please get involved with the level 3, level 4 work group. I'd like to see, I guess, maybe a show of hands, since we don't have the fancy computer system. Who would like to have we need a second stakeholders meeting. Knew we were going to have at least 2. A second stakeholders meeting, we can have it virtual. Okay, I know that's a probably easier thing to stomach. A virtual stakeholders meeting, possibly on a Friday morning or a Friday afternoon. I know that's a horrible concept, but something that wouldn't necessarily interrupt the work week like a Thursday does. I mean, I had to switch calls, switch, clinics, all kinds of things to be here today. But a second stakeholders meeting to discuss other points sometime within the next 3 months. Is that feasible? Or either you would come back here Any comments? Virtual? I'll go either way.
I think you're gonna get the same participation virtually as you do sitting in a room together.
All right, so in a room together?
Can we have a virtual option? I mean, it's just, I think.
We can always have, you can always have a
It's
virtual
vir-
option.
it's virtual right now,
Yes,
so,
we do have a virtual option right now.
sorry.
Sorry about that.
Yeah. Mandate.
All right, so hearing in person,
Hybrid.
hybrid,
yeah.
all right?
No, we can do hybrid and then we will utilize Mentimeter next time.
Right,
So
right.
we can get your rolling comments quicker and have them up on the screen.
Right.
And then that will really.
That will help. And we
make
may
it
go
look
back
nice.
over a few more points to get those back on paper and back on some data points again, while y'all have had a chance to percolate this for a little while. And then possibly another session related to later on about EMS, as Dr. Register was alluding to. Is that reasonable? All right, there's just several things we need to get on the bandwagon with and push forward over the next year to show some work to the GTC, but also get some of these critical points answered and addressed and moving on to the next section. Any other comments, any closing comments? Anybody?
No, I guess we can email out when, like, you know, we can send an email out about when and where the next meeting
Yeah.
will be. Hopefully we'll get that out in the next 2 weeks.
We'll try.
Yeah, I think we gotta.
Maybe we send out like a survey
work with
monkey?
You guys with
The
your,
dates and
with your
stuff,
date
yeah.
to get the data. out.
All right.
Yeah,
Anybody?
January.
I was gonna say that might be hard with the holidays coming up. I know people are gonna.
No, but we're,
Yeah.
we're looking at like February
February,
timeframe.
right.
so,
Yes.
Yeah,
Okay.
hopefully Nita will give us another day here.
Yes.
There you go.
Space.
All right. Thank y'all very much for being here. We appreciate it. Be safe going home.
Thank you, guys.